Okay, guys. So on Instagram, you would have seen there are so many influencers who are like, creating that buzz or aura about them. But when you scratch a little deeper, you will realize that it's all air, right? It's like the chips ka packet, which is like full of air and very little content. And then there are some influencers who might not be having very large number of followers, but they're delivering really great content. In a similar way, endocrine system is that silent warrior. It regulates everything, man. Blood pressure, sugar, sodium, potassium, stress, weight, you name it. I mean, the stress hormone of the body, cortisol, released from the endocrine system. So this is like that silent warrior or that so-called influencer who does not make tall claims. So with this, let's get started on the topic of endocrine system. First, we'll talk about the pituitary gland, which is the master gland in the body. And you'd be having a couple of cells, which would be on a histopathology, like the basophilic cells would be the blue ones. The acidophilic cells are obviously the pink ones, and there are some who would not be picking up any color, so there would be no staining property of the chromophobe cells. Now, why I'm starting that is because the most common tumor of the pituitary overall is not to be answered as prolactinoma. The overall most common tumor of the pituitary should be answered by you as a non-functioning adenoma. When I say like this, the query of a lot of students is, sir, what do you mean by non-functioning adenoma? The non-functioning adenoma is a tumor of the chromophobe cells, and chromophobe cells do not produce any hormone. So I can say that this tumor will produce a mass effect, but it will be biologically inactive. That means that it is not producing any hormones per se. But if I change the data, what is the most common functioning tumor of the pituitary? Then you very well know already on the slide, prolactinoma. And where is prolactin produced from? Then prolactin would be produced from the acidophil cells. In fact, there are two hormones which are produced by the acidophil cells of the pituitary. One of them is going to be growth hormone, and the second one is by the name of prolactin. And how to remember that? A quick hack: journal practice is awesome. Every doctor aspires to do journal practice. So GH, that is the journal practice GP part coming in here, growth hormone prolactin is awesome. That is acidophil cells, and the remaining four hormones from the anterior pituitary. You're aware the total of six hormones produced from the anterior pituitary. So TSH, ACTH, FSH, LH, they are basophilic. They are derived from the basophilic cells, and that's why the terms used in MCQs might be a basophilic adenoma. So if you read a basophilic adenoma, these are the hormones which any of these can be overproduced. But if you feel or read the word acidophilic tumor of the pituitary, then it's either going to be a growth hormone excess or a prolactin excess. And that's what I'm going to focus on: acromegaly and prolactinoma as two important topics. Now, if the size of the pituitary tumor is going to be less than 10 millimeter, we will call it micro. If it's more than 10 millimeter, macroadenoma. Overall, the most common, I'll repeat again, tumor of the pituitary is non-functioning adenoma, does not produce any hormone, and the functioning tumor is prolactinoma. Before I describe a manifestation, another parallel kind of a question, a parallel similar spirit of a question. If it says what is the most common tumor of the pancreas versus functioning tumor of the pancreas, the answer will again vary. When it comes to the most common tumor of the pancreas, your answer would be given as PPoma. What do you mean by PP? Pancreatic polypeptide oma. Pancreatic polypeptide is produced from the F cells of the pancreas. It is again biologically inactive. What does PP stand for? Your answer would be PP stands for pancreatic polypeptide. This hormone or this product is again biologically inactive. It does not produce any change in the blood sugar. Like, in the pancreas, we have insulin, we have glucagon, so they fluctuate the blood sugar. But pancreatic polypeptide does not have any effect on blood sugar, does not have any effect of electrolytes. So that's why I'm saying it is a biologically inactive molecule, but it will produce a mass effect. It will squeeze the CBD, so it will cause obstructive jaundice. And then if I change the question to what is the most common functioning tumor of the pancreas, then you very well know, even the surgeon would have talked about it, the most common functioning tumor of the pancreas is insulinoma, for which we always read about Whipple's triad. Now, before I talk about Whipple's triad, coming back, like this was a similar kind of a question. Commonest tumor of pancreas, functioning tumor of pancreas, coming back, pituitary, non-functioning adenoma, that's a chromophobe adenoma versus a acidophilic adenoma, that is prolactinoma. The problem is that this tumor originates very, very close to the optic chiasma. Optic chiasma, if it's compressed, we get a bitemporal hemianopia. Well, no prizes for guessing that. Because the examiner knows that you can answer bitemporal hemianopia, they will ask you a concept which is as follows. The pituitary adenoma is growing upwards towards the optic chiasm is on the top and the tumor is from the bottom. It increases in size and it presses on the optic chiasma from the bottom. So because the pressure is from the below, it will basically squeeze the inferior fibers which are traveling through the optic chiasma. Now the inferior fibers are actually carrying the vision from the superior temporal fields. So manifestation which is earliest to develop in the patient would not be a bitemporal hemianopia. It would be pie in the sky. I'll repeat the features once again. Let's imagine this is the pituitary, the optic chiasm on the top. The tumor becomes bigger, bigger, bigger and squeezes on the inferior fibers. Now pressure on the inferior fibers, because anatomically speaking, the inferior fibers are carrying the vision from the superior temporal fields. Therefore, you get a superior temporal quadrantopia, which is basically called as pie in the sky. So this is again one of the questions that said, what is the early manifestation that would be developing in a patient who's having a pituitary adenoma? If it becomes a macroadenoma, macro means more than 10 millimeter in size. First, it will cause a pie in the sky, and then gradually the manifestation of BTH, that is a bitemporal hemianopia, would be developing in the patient. Now, in the light of this data, let's focus on the first comparison, that is with respect to a tumor which is causing excess production of growth hormone versus excess production of prolactin. I'll be describing two acidophilic acidoma as adenoma based tumors, that is prolactinoma and acromegaly. For prolactinoma, the buzzwords in the clinical bites are based on the fact, and this line will help you understand the entire prolactinoma topic in one single line. Dopamine, remember, is inhibitory to prolactin, and prolactin in turn is inhibitory to the effect of LH and FSH. So this young lady, she's having a prolactin producing tumor. It's a microadenoma, let me say 2 millimeter, 3 millimeter, 4 millimeter, whatever. When it will increase in size, it will contribute to inhibition of the levels of LH and FSH. Now you know that LH is responsible for that spike that occurs at the type of ovulation. I mean, we have what is in physiology called as a LH surge. Now, if the LH surge will not happen, then the follicles will not develop. So this lady will be having difficulty in conceiving because she would be having anovulatory cycles. And if you suppress the levels of FSH, then like the follicles are not going to develop. So what I can say is that the question will basically talk about a lady. Depending on the age group, he might use the word primary amenorrhea, secondary amenorrhea. Like she's already had one kid. Now, once she's developed a prolactinoma after she had her first baby, she can be developing a secondary amenorrhea as well. To cut the long story short, the question will basically focus on the concept of infertility developing in this lady, which could be like primary or secondary. But obviously this infertility word will make it easier for you. So he'll begin by saying a young lady comes to the doctor with complaints of anovulation, amenorrhea, or like she's not being able to conceive. Along with this, the question will also mention the buzzword, which is very simple and straightforward, that prolactin will act on the acini of the breast. By acting on the acini of the breast, it will result in milk production. So though she cannot conceive, she's not had a baby, right? That I'm saying that she's not lactating, but she's not being able to conceive. And there would be galactorrhea described in the question. The question can also begin with a male. Now, in a male, will you have a galactorrhea? Yes, we will have a galactorrhea, but obviously in a male, you would not have anovulation and amenorrhea. So there it would be written male patients with infertility and development of galactorrhea. Contrast this with acromegaly. Acromegaly is a disease where the growth hormone excess would be beginning, but this growth hormone excess will be developing after puberty. If the growth hormone was increasing due to a pituitary adenoma before puberty, I would have used the word gigantism. Gigantism is what is discussed in pediatrics, but we're talking about adult patients. So growth hormone excess after puberty is what is acromegaly. And because this growth hormone excess is after puberty, that is why the height of the patient will not change. You see, height tends to increase only up to the age of the puberty. After that, the ossification centers fuse with the main shaft of the bone. So in this particular patient, because the tumor is developing after pituitary, so the ossification centers have already fused with the shaft of the bone. So height will not change, but what will change is the size of the hands and the feet. Acro basically means that this guy will be requiring, like, you know, maybe like Western countries, they go out because it's very cold. So they might be requiring gloves. So this patient is having a requirement of new pair of gloves every month, or the size of the foot will increase. So this guy is going to a Nike store, Adidas store, those boot for those basketball players, no, they have big feet, so like those big shoes are being purchased. But very soon the size of the foot might be so big that the guy might be requiring custom made shoes. I can give example of that WWE wrestler, right? Khali. I mean that chap had acromegaly, and I mean the size of the feet are very big, the size of the hands are very big, and I mean one of the legends that we have had. I mean for Indian to go into WWE, you require an extreme level of fitness. So hats off to the dedication of Khali, the great, I can say. But then the height will remain the same, and the words written in the question would be spade like hands. The lower jaw will become prominent, that is prognathism. And don't be surprised if he mentions the word galactoria. This happened in FMG exam. One of my students pinged me after the paper कि sir galactoria भी लिखा था. तो यार acromegaly जो होता है ना, in that you could be having is a somatotroph and a mammotroph adenoma. You see, I'll just write it here. If they ask you from physiology, what is the most abundant cell in the human pituitary, then the most abundant cell of the pituitary should be answered as growth hormone producing cell. And this most abundant cell of the anterior pituitary. Obviously, I'll discuss posterior pituitary separately. Most common, most abundant cell of the anterior pituitary is a somatotroph. So what I'm describing to you at the moment is a somatotroph adenoma, and sometimes you could be having a somatotroph as well as a mammotroph adenoma. I mean, both the cells will start proliferating more, and as a result of this, I can say that person can be having presentation of galactoria. So don't be confused. I mean, you have to understand this fact that if a tumor can develop in the somatotroph, it can develop in mammotroph also. So galactoria can be given in the question, then the weight will increase, and increase in weight will cause insulin resistance, so they would be impaired glucose tolerance. The examiner will deliberately give you those diabetic cutoffs. No, I'll describe those cutoffs later. You are anyway aware of them. Fasting more than 126, 2 or more than 200. So no need to note them down. They are like going to be described. And then because the weight will increase, peripheral resistance will increase. So hypertension will also be there. They'll increase the length of the question. But what you have to pick up is that significant increase in the size of the hands and the feet and the lower jaw of the patient, that is prognathism. And once you pick up the clinical bites, it becomes relatively easy. The screening test of these patients have been asked investigational choice. For prolactinoma, we need to go for serum prolactin levels. They'll always be spiking, and we then need to do a MRI pituitary with contrast to demonstrate the cellular mass. In contrast, in acromegaly, if he says what is the screening test, now here I find people making mistakes, so you have to be careful. Your answer would be that I'll be checking the levels of somatomedin. Somatomedin will cause somatic growth. And what is that somatomedin? The name is insulin-like growth factor 1. In the MCQ, IGF-2 will also be given. Insulin-like growth factor 2 is required in the human body before the birth of a child. I mean, IGF-2 from physiology perspective is for prenatal growth, and for postnatal growth, it is IGF-1 levels which would be significantly elevated. And then comes a very shocking statement. If you're listening to for this for the first time, what is the investigational choice for diagnosis of acromegaly? Asked upteenth number of times in NEET PG and also in FMG exam. Oral glucose tolerance test. I mean, first time when we read it, it's like, are you kidding me? Oral glucose tolerance test, that is for diabetes. Yes, I agree. But today we are using glucose to demonstrate failure or suppression of growth hormone production. Guys, if you and me will consume sugar, our growth hormone levels can be suppressed. Obviously, like all hormones in the body are never produced in a constant fashion. Hormones in the human body are always produced in a pulsatile fashion. So this pulsatile production of growth hormone is present in excess in a person of acromegaly. What I'm trying to say is that in you and me, we can suppress this pulsatile production by consuming sugar, but a tumor will not respect physiology. Tumor is like, tu kaun hai bhai? I don't give a damn to you. Tumor never respects physiology. He says, I don't give a damn to you. And therefore, in spite of giving 75 gram of glucose, the growth hormone levels will remain elevated. No need to remember the cutoff 1 nanogram, etc. Sometimes given in picogram, sometimes given in nanogram. It is failure to suppress growth hormone that is to be remembered. And once you've done the comparison, then it's the interventions that would be done. Here for prolactinoma, I get a lot of queries कि सर प्रोमोक्रिप्टन आंसर करना है या कैबरगुलिन आंसर करना है. भाई क्वेश्चन ऐसे DOC करके नहीं आता. The question doesn't come like what is drug of choice. He'll give a scenario. Scenario would be like this lady had infertility, no? So why will she come to the doctor? I want to conceive. Suppose she has one baby and she says, doctor, I want to complete my family. Most people in India would like to have at least 2 children. So if the question is giving you infertility, then they expect the answer is bromocriptine because they want to see that you know what is a pregnancy safe drug, bromocriptine. But if he himself says patient came mainly for the complaints of galactoria and patient does not want another baby, then I can be using another drug. The advantage of this drug is cabergoline is that this one dose of this will act for as long as 14 days. So, the compliance part also clicks. You see, to take a tablet daily is not a very practically feasible problem. People tend to miss dosages. So cabergoline, even if they miss a couple of dosage, doesn't matter because it is a long-acting molecule. The question is, can we give cabergoline in a pregnant lady? Answer is yes, but in the first trimester, bromocriptine is safer, so I'll be using it. So the point is, there is no controversy, guys. It's not that some teacher has said bromocriptine, somebody has said cabergoline. If MCQs himself beginning with the word infertility, that means that he wants to assess your knowledge of the fact that which is a pregnancy safe drug. But in contrast, if the patient has completed the family, then cabergoline would be required. And most of the time for the topic of prolactinoma, there is no requirement of any surgery because the tumor is very, very slow growing. But yeah, if it becomes very big, then maybe a transfemoidal surgery might be required in the patient. In contrast, when it comes to acromegaly grows fast, guys. Acromegaly, like if it becomes a macroadenoma, as I've explained, macroadenoma, the size would be usually more than 10 millimeter, 1 centimeter or bigger. You see, you might say, sir, 1 centimeter kya hota? It's so small. I agree, man. But look at the area, the critical area of the brain where it is located. 1 centimeter in brain is big deal. So in a macroadenoma, if he himself begins by saying patient has already started having visual field deficits. If in the question of acromegaly, the examiner begins by saying that initially the patient was having that pie in the sky thing, and then subsequently there is a development of bitemporal hemianopia. If in the question bitemporal hemianopia is given, mark my words there, if in the question bitemporal hemianopia is present, that means that indirectly the examiner is trying to see that that this manifestation will be seen with a macroadenoma. I repeat my fact. If bitemporal hemianopia is given in a question, that means that the patient is having a macroadenoma, and therefore I would like to go in for surgery because I would like to go in for surgery as early as possible. The reason of the rationale is that I don't want a permanent loss of vision in a patient, so transfemoidal surgery. Now let's to make it more extreme. Tumor is so big that he says MRI is showing in this patient. We'll do a imaging in this patient also. I mean, MRI, I've not written MRI on the right hand side because it's an obvious thing that for any cellular mass, a MRI pituitary would be done. So I was focusing on the biochemical evidence. But yeah, I mean, if you ask me what imaging would be done, then the imaging that I'll do in this patient will also be MRI head. If it demonstrates a tumor more than 1 centimeter, cool. But if he says the word that there is an infiltration into the cavernous sinus, or he says that the patient is having a large, huge tumor, which could be extensive tumor in the brain is the word that can be used, then I would like to first shrink the tumor. You see, if a patient is a high surgical risk, macroadenoma invading the cavernous sinus, I would like to first shrink the tumor slightly. And then after shrinking the tumor, I would then proceed with surgery in the patient. So even in a macroadenoma invading cavernous sinus, finally, I might decide to operate. But initial management of this patient would be that we would like to shrink the tumor by using a drug. And I'm deliberately prolonging it because I don't want you to look at the notes, guys. I want you to be very good at this, that what drug can be used to shrink a pituitary macroadenoma? Your answer is octreotide. Yes, guys, the same octreotide that you will be reading for secretory diarrhea, the same octreotide that you read in portal hypertension management, the same octreotide, but in a long-acting format. So the answer is lanreotide. We will be giving lanreotide injections. That is what he wants to hear. And this was again an FMG exam question, that patient is having a macroadenoma infiltrating into cavernous sinus. What is the first line approach? So I'll not go ahead with surgery. First, I would like to shrink the tumor, make it more comfortable for the surgeon to operate. Lanreotide is a octreotide derivative. Lanreotide is a long-acting derivative. Then comes another question, which is from the NEET PG. वहां पे वो situation change कर दिया, बोला operation is already done. Transfemoral surgery of the patient has been done, but there's a recurrence of the disease. There's a residual disease, or he might say the word recurrence. Either of the two. I'll write both of those terminologies here. One possibility is he may say residual disease after surgery. Second, he may say that transfemoral surgery was done, but there is a recurrence after, because the surgeon is operating, but he'll operate conservatively. If you aggressively operate, it might even cause a Sheehan syndrome. The entire pituitary might go bust. So the surgeon has to be conservative while operating and remove only the tumor related to somatotrophs. Now, if there's a recurrence, there is a residual disease, then we will have to use a molecule which will basically block the action of the growth hormone. Now, person has already gone surgery again, so he will not agree for a second surgery. No? He'll not agree for a second surgery. So what we will do is we will block the effect of we will block the receptor of the growth hormone. तो growth hormone receptor blocker जो होता है, growth hormone receptor blocker is what is called as pegvisomant. Even if you read the name, no, pegvisomant, somant, basically somant means it is blocking the somatic growth. Somatic growth means tissue growth of a patient, and this patient will be having, like अगर हाथ में रिंग डाला हुआ जैसे acromegaly वाले patient है तो finger thickness will increase, size of the toes will increase. So acromegaly, the size of the hands and the feet become bigger, and you have like increase in, like I can mention a radiological parameter in these patients also, like the x-ray of the foot can be described for acromegaly patient, and he may write the word increase in heel pad thickness. This is just a surrogate term. Instead of writing the word increase in the thickness of the finger, increase in the size of the hand, increase in the size of the foot, increase in the size of the toes, the examiner might be using a surrogate terminology which I've written at the moment. Heel pad thickness would be increased in patients of acromegaly. What that basically means is somatic growth is occurring in the tissues. The most important information on this slide is the investigational choice for diagnosis of acromegaly, that is the oral glucose tolerance test. So this is a quick comparison between two diseases of the anterior pituitary that I've currently mentioned before you. And what I'll do next is discuss about endocrine emergencies that they love to ask. More details of these endocrine emergencies are in the subsequent part, but here, because we'll first focus on questions, that is like, what is the first line intervention? It will be 3-liner, 4-liner question. It will not be 1-liner. It will be 3-liner, 4-liner in FMG exam. In NEET PG, it will be 1 to 2-liner only. That's what is till now, what is happening. They can swap the data at any point of time. FMG exam में वो जैसे लेस का चिप्स होता है ना, पैकेट हवा भर देते हैं, तो it will be 4-liner to fatigue you out. And in FMG, in NEET PG exam, very tricky options. It's only 2-liner. People think यार 2-liner है ना आसान होगा. नहीं, it's not that way, right? That 4-liner is easier because there he will have to give some hints in the question. So people are able to, like, people get bogged down with the size. I tell you, in my opinion, that long stem question has more chances of scoring because some buzzwords would be given. They have to be descriptive of the buzzwords. In NEET PG, what he will do is deliberately क्या करता है कि all those, like, terminologies that I was using, he will be very selective about them, or he'll try to be very concise about them. So the chances of missing them will be relatively higher. Anyway, coming back to the agenda, diabetic ketoacidosis. For diabetic ketoacidosis, the random blood sugar should be always more than 250. You would be remembering that whenever we deal about, diabetes mellitus, the random blood sugar should be more than 200 with symptoms. But today I'm talking about not 200, but more than 250. For the ketonemia component, I mean, either it can be ketonemia or it can be ketonuria. So how will the examiner describe the word ketonemia? Is that he might write this test written, like he may not write the word ketones, but rather one of the ketones names would be given, that is beta hydroxy butyrate levels in this patient might be elevated. If he doesn't want to write it, then never an issue. I mean, to make it easier, he will write ketosticks of the patient is 4 plus 3 plus. That means that ketonuria is present, because if ketonemia is there, ketonuria will also be there. And alphabet A will be for the acidosis component. That is very traditional. So he will be giving a ABG report in which the bicarbonate values of the patient normal are 22 to 26. Here the bicarbonate values would be less than 15 milliequivalents per liter. So DKA is to be satisfied. He will say what is first line intervention. First line intervention is load the patient. Load the patient with normal saline, because a lot of these patients would be having significant dehydration, and because of the GI losses there would also be hypokalemia present. So we will also add potassium chloride. They will not ask you the dose of how much potassium chloride that is to be added. That will by default be given in the question, like 40 milliequivalents per liter. That's added to the bottle of IV fluid. But the first line intervention is normal saline. And when it comes to the drug of choice of this patient, we have to give insulin. So he will ask what kind of insulin would be given to the patient. That is regular insulin. Also to be remembered is, like, you have to start this insulin after 1 hour. Like he will try to write down the dosages also, like 0.05 to 0.1 unit per kg per hour of infusion is to be given to the patient. That is okay. What you have to understand is that there must be a time lag of minimum 1 hour. There should be a time lag of at least 1 hour between, starting normal saline and giving insulin drip in the patient. He says don't rush into giving insulin drip, because insulin will also be sending potassium inside the cells. So the first intervention would be to give potassium chloride to the patient. So next up is a hyperglycemic hyperosmolar state. This is more common in type 2 diabetes and will be having an insidious onset of presentation. DKA has a stormy onset of presentation. Here you'll usually talk about a child where insulin was not given and therefore the child went into diabetes diabetic ketoacidosis due to insulinopenia. But in hyperglycemic hypersmolar state, the sugar value will be given to be outrageously high, something in the range of 600 milligram, and this is gonna draw water. I mean, what this sugar will do is it will draw water from inside the cells. So I can say that this condition has a very significant amount of intracellular dehydration, and that explains the manifestations of coma occurring in this patient, because the neurons will also be affected. And well, why have I written ketonemia for this patient? Because if somebody will not eat anything for 2 days, right? This guy was drowsy, unconscious for maybe 1 or 2 days. So the glycogen in the liver is finished. Now, if the glycogen in the liver is finished, then like how does the energy be produced? It's produced from burning of fats, and burning of fats will produce ketones. But the magnitude of ketonemia in this condition is not sufficient to cause development of metabolic acidosis. So acidosis is very what you get with respect to diabetic ketoacidosis, which causes cerebral edema. But here the main problem is that of intracellular dehydration. And if he says what is the first line intervention, even here our first line intervention would be to give normal saline to the patient. And after that, obviously the treatment of both of them is same. Here also, if he says what is the type of insulin that we'll be using, it's a regular insulin. The advantage of regular insulin is that it can be given subcutaneously as well as it can be given intravenously as well. But as such, there is no requirement of potassium chloride in these patients, because when it comes to DK, there is a lot of vomiting component present. There's a very significant GI loss that is happening in the patient, and along with that, insulin will also cause redistribution of potassium, understandably. But like considering the hypokalemia component being predominant, KCl was added to diabetic ketoacidosis, but is usually not required for management of hyperglycemic hypersmolar coma. Don't be under impression that DK is only seen in type 1 and hyperglycemic hypersmolar state is seen only in type 2. It can happen vice versa also. There could be a question of type 2 diabetes and the person could end up with DKA, or like type 1 diabetes with hyperglycemic hypersmolar state. But what is more common is DK is more common with type 1 and HHS is more common with type 2. Then another important complication for diabetics is severe hypoglycemia. Well, as far as the cutoff for hypoglycemia is concerned, you would be familiar that the values less than 54, the options in the MCQ were like 45, 54, 60. So a lot of guys answered 45. That's for babies, right? But for adults, the textbook says less than 54. And first thing is because the patient is unconscious, so I need to secure airway and get an IV access. And after giving an IV access, what will I do subsequently in the patient is adult patient, I will be giving 25 to 50% dextrose. If it is a child, I will be giving 10% dextrose to the patient. So the message here is that treat hypoglycemia. But then at the same time, he might create a situation for you where the doctor is not being able to get an IV access because patient is having convulsions. So the whole body of somebody is checking very vigorously. When you try to put the cannula can get countered also. You tried putting a peripheral line. Your senior resident tried putting a jugular line, and both were unsuccessful. So failure to gain IV access. And now I am like staring at a patient who's having convulsions and could aspirate and die. So in those circumstances, like what I can give for this patient is glucagon. Glucagon is available as a subcutaneous injection and can be given to patient. It will cause glycogenolysis and the sugar of the body will begin to rise. So if we specifically introduce the situation, the doctors were unable to get IV access, it is glucagon. Otherwise, standard answer is 25 to 50% dextrose. For children, it is 10% dextrose. Then comes an important endocrine emergency by the name of thyroid storm. Why do you get a thyroid storm? It can be pre-operative, it can be intraoperative, it can be post-operative. Don't be under impression that it is only like intraoperative scenario. It can be at any of the three sites. Well, the main reason is failure to achieve euthyroid status. In all patients with Graves' disease, first we must be giving antithyroid medicine to the patient. That could be in the form of carbimazole or it could be in the form of propylthiouracil depending on the pregnancy or non-pregnant status. But without achieving euthyroid status, if I do perform surgery or if I give radioactive iodine to the patient, any other two scenarios, it could be the patient was given radioactive iodine for thyroid ablation or surgery was tried without achieving euthyroid status, it's a disaster. Like the thyroid hormones that will spike in the body, they will cause excessive sympathomimetic stimulation that can contribute to arrhythmia. This is a question from the FMG exam. He said, what is the leading reason of death? Why person is having during the thyroid storm? Your answer is arrhythmia. The second one is heart failure. This was really a difficult question because both are given in Harrison, but first answer is arrhythmias followed by heart failure. And how do you standardize like what is thyroid storm and like diagnosis of it? Then we have a scale that is called as Birch-Watt-Oskwy scale. Bit of tongue twisting name, no? Birch-Watt-Oskwy scale. Now, like, what's the initial treatment? So initial treatment is beta blocker, that is, we'll be giving propranolol for this person. At this, the query of a lot of students is, sir, we have read in pharma that the drug of choice for management of this condition is propranolol, and you are marking it only as a first line drug. Yes, guys, the textbook says that this is first line drug because it will control the sympathomimetic stimulation, but it is not the drug of choice. You can see our objective here is to talk about endocrine emergencies from the first line perspective or drug of choice. All these questions would be long stem only, but finally when they will ask you what is the treatment, you have to be very, very precise. So for thyroid storm, according to Harrison, the drug of choice is propyl thiouracil, that is PTU. Why propyl thiouracil? He has even also given a rationale. The rationale is that propyl thiouracil causes inhibition of conversion of T4 into T3. You see, the active form of the thyroid hormone is actually T3. That is the one that is having biological effects and is also causing sympathomimetic stimulation. So I want to block the production of the active form of the thyroid hormone, that is T3. Propyl thiouracil cannot do this. On this slide, I think the most important common error that students make is that they answer the drug of choice for this condition as propranolol, whereas Harrison categorically states, so I'll be just marking this, Harrison says that the drug of choice for this condition is propyl thiouracil. Now I agree to the fact that propyl thiouracil is not available in IV format, neither in India, neither in America. So how will I give propyl thiouracil to the patient? One route of administration can be rectal, or another one can be that I can put a NG tube in the patient, but at least the drug delivery can be done. No. So the main message is propyl thiouracil is the DOC. And why do you use propranolol in a patient? A quick recap. Propranolol is a non-selective beta blocker, so it will only help you control that beta 1 stimulation of tachycardia, which can trigger heart failure, and second, it will control beta 2, which is like in the muscles and is producing heat also, because hyperthermia will also be present in a patient. So one more point that I just want to add to the discussion of thyroid storm is that I will also be doing an external cooling of the body of the patient. We will be requiring ice packs for management of this patient. This is totally in contrast to the subsequent condition that I'll be describing, that is myxedema coma, where body temperature will decrease. So I will rather have to do rewarming of the body of the patient. But in thyroid storm, thyroid hormones cause calorigenesis. They produce heat in the body. Because of the calorigenesis component, because the body temperature in this condition will spike, therefore there would be external cooling that is required. And that also says to me, like, I can say that if you get a question on an unconscious, unresponsive Graves' disease patient with high grade fever, if you ever get a question on a patient of Graves' disease or like thyroid disease patient given with very high temperature, then assume it that the question is on thyroid storm. In the same spirit, if you get a question on hypothyroidism and he mentions that the patient's body temperature is significantly low, I repeat my statement. I was earlier describing hyperthyroidism. So obviously thyroid hormones would be contributing to increase in thyroid hormone, like increase in the body temperature. Now calorigenesis is lesser, so there would be decrease in the body temperature, and this decrease of body temperature is the reason for development of coma. Yes, guys, in myxedema coma, the next endocrine complication that I'm describing before you, the body temperature, that is the core temperature, will go less than 35 degrees Celsius. It could be mild, it could be moderate, it could be severe hypothermia. Mild hypothermia is 32 to 35. Moderate is going to be 28 to 32, and severe is less than 28. What I'm trying to say is that if they give you a thyroid question in which hypothyroidism is described in the patient, and then he says the patient became unconscious, unresponsive, not responding to verbal commands since last night, patient brought to the hospital today morning, and body temperature is low, then the first thing that you need to think of would be myxedema coma. You see, hypothermia is a manifestation that is usually seen in cold countries like America, or if I say to you, somebody is in Siberia in Russia, somebody is in New York in the month of December, or the Arctic storm hitting minus 20, minus 30 degrees Celsius, understandable hypothermia can occur. That is environmental hypothermia. I am telling you a medical cause of hypothermia, and therefore the first line management is because patient is in coma. So because coma word is there, your answer would be secure there. Obviously, external rewarming will be there, but he will arrange them in the correct order. So if you read the word coma ever in your career, then I have explained even in CNS also that when a coma is present, you have to secure the airway, external rewarming, then we give steroids. On this, the query a lot of students is, sir, why are you giving steroids? This is not like asthma, COPD exacerbation that you're giving steroids. This is not also Addisonian crisis. Then why are you giving steroids? Well, lots of time, Addison disease can be coexistent with Hashimoto's thyroiditis. You see, both are autoimmune conditions. Both are autoimmune conditions. Hashimoto is also autoimmune etiology, and Addison disease also autoimmune etiology. So to prevent the unmasking of Addison disease in a patient, I would like to give hydrocortisone to this patient. And then obviously the main drugs that we'll be using is thyroid hormone replacement. So this time the patient is sick, he or she cannot take orally. So I will be using liothyronine in this patient. And along with liothyronine, one more drug. In fact, you guys tell me, liothyronine is T4 or T3? Yes, it is T3 derivative. I'll just write it once again. You see, in the exam, IV levothyroxine is not what he wants to hear. Obviously, this will be in the options, and this is the first answer because levothyroxine is simple T4. But the examiner also wants to know that you are aware of the fact that there is a T3 derivative that can be given to the patient, that is liothyronine. So most of the time in the exam, levothyroxine will not be in the options. If it is in options, great, that is the first answer because I need to provide T4, it will get converted into T3. But then most of the time the examiner wants to hear the name liothyronine, which is exact T3 derivative or is a T3 extract. These are 4 common endocrine emergencies. I'll just summarize them in next 30 seconds. For diabetic ketoacidosis, the first line management is NS plus KCl and regular insulin. For hyperglycemic hypersmolar state, sugar would be usually very high. It's normal saline with the insulin drip. Treatment is same. For hypoglycemia, we don't need to discuss, very straightforward. And for thyroid storm and myxedema coma, body temperature will be significantly high and significantly reduced respectively, and arrhythmias can occur in thyroid storm. That's why we want to be proactive and we need to give NG tube via NG tube propylthiouracil because it's not available in IV format and is the drug of choice. And for myxedema coma, you obviously will have to give levothyroxine, but you will also give liothyronine along with hydrocortisone for management of these patients. More technical aspects to follow for these in the full descriptions, but at the moment the objective is to finish the table of first line management versus drug of choice. Let's continue. Addisonian crisis. Addisonian crisis is an example of which variety of shock? So your answer is that Addisonian crisis is an example of distributive shock. While I write down the subsequent treatment, can you tell me any other cause of distributive shock, guys? Any other example of distributive shock? The mnemonic for distributive shock to be remembered would be SAN. The first example would be septic shock. I mean, the highlight of distributive shock is that the systemic vascular resistance will become subsequently reduced. Let's just practice this here. We have read about hypovolemic shock, obstructive shock, cardiogenic shock, but today I'm telling you regarding distributive shock. SAN, septic shock, is an example of distributive shock. The systemic vascular resistance is significantly affected. Alphabet A would be for Addisonian crisis. As I've explained, most of the time Addisonian crisis can be due to 2 important reasons. One can be sudden stoppage of steroids. Whenever you give steroids to patient, tell them that if you don't trust me, don't take my treatment. You want to take homeopathic, Ayurvedic, okay, we are okay with it. You can try alternative medicine also. But don't do this fact कि steroids एकदम से बंद नहीं करने होते. Always remember that never stop steroids suddenly because they can cause a Addisonian crisis in a patient. The third cause for distributive shock is neurogenic shock. So this is itself a miscellaneous question that I have discussed before you, causes of distributive shock where the systemic vascular resistance is substantially low. So I need to first load the patient with fluids. So normal saline again is becoming the fluid of choice in this case. But then the drug of choice for Addisonian crisis is IV hydrocortisone. Hydrocortisone has equal mineralocorticoid as well as glucocorticoid activity. That is why I'm preferring it. You see, I can use dexamethasone also, but then dexamethasone has predominantly glucocorticoid activity, so it will not stabilize the blood pressure of this patient. What happens in Addisonian crisis, which an example of distributive shock, is that blood pressure will crash. Obviously, because I'm saying the word shock, blood pressure will crash. What is the big deal? The big deal is sugar will also crash because cortisol levels will be dropping. You would have read about so many causes of hypotension, cardiogenic shock, septic shock, obstructive shock, hypovolemic shock. All these are standard examples where like the blood pressure becomes lesser. But the only scenario in your whole career where you will read hypotension with hypoglycemia is Addisonian crisis. One of the important reasons why Addisonian crisis can be triggered. So I'll just write down the cause also. One of the causes is sudden stoppage of steroids. The second cause I will say verbally. The cause is meningococcal infection. That's called as Waterhouse-Fridson syndrome. I will be describing Waterhouse-Fridson syndrome to you in my neurology discussion, or I think if you've already listened to it, then you'll be familiar that meningococcus can cause bleeding in the adrenal gland, and that would be Addisonian crisis. But overall, the number one that can be remembered is sudden stoppage of steroids. Then we come to pheochromocytoma, hot favorite of our examiner, and he will give you a scenario of intraoperative hypertension. He will say that during surgery, when there is a tumor handling, because you see, the pheochromocytoma as an endocrine tumor has to be resected, so the surgeon will have to do dissection. When you do dissection or tumor handling, this tumor is producing very hell amount of catecholamines. They will be released into the circulation, and that will cause a BP surge. So the main problem is intraoperative tumor manipulation being done by the surgeon. The surgeon's hands are putting pressure on the gland. There is retractors that are being used, so there is a surge of catecholamines. And therefore, what drug I should be using during surgery to prevent left ventricular failure? Because see, blood pressure, if it rises very suddenly, it causes LVF. If hypertension is long standing, something like 20 years of hypertension, you get left ventricular hypertrophy. But if it's a sudden onset hypertension, we end up with manifestations of left ventricular failure. My patient will develop pulmonary edema on the operation table and will die. Sir, left ventricle failure causes death in majority of cases, even when there is no surgery being done. I mean, LVF due to any reason can contribute to death in a matter of minutes. On operation table, the death will even be faster because patient is under the effect of anesthetic drugs. They anyway cause vasodilation. All anesthetic drugs cause vasodilation, so the crashing of BP can be very, very fast. So, I mean, like, pheochromocytoma is that peculiar situation where during surgery the BP is spiking. And that for spiking of blood pressure, I need to bring the BP back to normal. I don't want to decrease the blood pressure. By decrease, I mean I want to decrease to normal values. I just want to maintain a normal blood pressure value during a pheochromocytoma surgery. That is, sodium nitroprusside is the best drug that would be used. And in NEET PG, there was this controversial question where he said, what can be used both intraoperatively and preoperatively? Now here the answer is not phentolamine, because phentolamine, if I give just before surgery, then it can contribute to like worsening of intraoperative hypotension in a patient, because anesthetic drugs are vasodilators. Bleeding can also be occurring during surgery. So what drug can be used specifically, like both intraoperatively and preoperatively for these patients, is like a calcium channel blocker like nicardipine. Intraoperatively, see, the most important thing is intraoperatively I'm using sodium nitroprusside, but preoperatively also, if he says what is the drug that can be used, then it is nicardipine, which can be used both pre as well as intraoperative. Let's do a recap here. Pheochromocytoma, usually in the previous years, what they used to ask was, what is the drug of choice? So this is optional if you want to note down. He said preoperative management. That should be done in patients of benign pheochromocytoma. I will be describing pheochromocytoma subsequently in the later part. At the moment we're handling emergency, if he just says preoperative management of benign pheochromocytoma from the perspective of hypertension, you see, hypertension in preoperative management for a benign pheochromocytoma, if is the question, then the drug of choice for this is a non-selective alpha blocker. This non-selective alpha blocker that we use is called as phenoxybenzamine, and along with phenoxybenzamine we also give a beta blocker by the name of propranolol. So in preoperative period, I will first be starting the patient on non-selective alpha blocker. It is alpha plus beta, not beta plus alpha. If I will give beta plus alpha, the BP of the patient can crash. But for preoperative hypertension, it is phenoxybenzamine. And once the blood pressure is controlled, then I will tell the patient that the second medicine to be taken, preferably after breakfast, is propranolol. The rule is that in preoperative management of a benign pheochromocytoma, the algorithm says use alpha plus beta blockade. Beta plus alpha is contraindicated. Now this is routine information. This is routine information. Preoperative hypertension for a pheochromocytoma of the benign variety. Then like examiner knows that you read it well. This concept has become old now. First we will give alpha blocker, then we will give beta blocker. If I will give reverse, the BP will crash. So he stopped asking it. Now what is he asking you? He is now asking you regarding one, intraoperative hypertension, sodium nitroprusside. Second is what drug can be used both intra as well as preoperatively, that is nicardipine. So like lots of time you will notice that in the exam, the routine information nowadays is becoming very cliche. I mean, because everybody is knowing it, the level of competition is also increasing. So like the message is that traditional information has to be read, but then you need to step up. You know, I'm trying to push your level up to where the examiner expects it to be. Sodium nitroprusside is used two times. One with respect to like hypertensive encephalopathy, and second is with respect to pheochromocytoma. And like in the cardiovascular system, I discussed all these emergencies with respect to hypertension. Then comes hypercalcemic crisis. Hypercalcemic crisis, most of the time, the cause of this would be lung cancer. And which lung cancer causes hypercalcemia? Then it is not small cell cancer / oat cell cancer. Small cell or oat cell cancer can cause SIADH, but not hypercalcemia. Rather, it is squamous cell cancer of the lung. Squamous cell cancer of the lung will be producing PTHRP, that is parathormone related peptide. What does RP stand for? Related peptide, and therefore the calcium levels will begin to rise. You are aware that when calcium values will usually go in excess of 13, the moment normal calcium in the body is normal calcium is 9 to 11, less than 7 is tetany, more than 13 will cause an issue in a sense that it can cause a cardiac arrest. Because this is so dangerous, hypercalcemia, that the heart of the patient can stop. Then I need to be aggressive. What I mean by aggression is I will be giving normal saline to this patient again. 4th time normal saline is coming in the discussion. So let's practice this. Normal saline being used for DKA, then for hyperglycemic hypersmolar state. The 3rd time I said normal saline was Addisonian crisis, and now it is being used for hypercalcemic crisis in the patient. But this time the examiner also wants to hear that I'm aware that to the bottle of normal saline, which will cause dilution. Normal saline will cause dilution, so calcium values will go down to like 12.8, 12.9 from 13.1, 13.2. So I'm just hoping that, the critical levels of 13 are not breached. Now to the bottle of IV fluid, I will add furosemide. Why do we add furosemide? A recap of pharmacology. You are all aware furosemide is a loop diuretic, and the pharmacologist would have told you that loop diuretics lose calcium. I repeat my statement. Loop diuretics lose calcium. So if I will be having a calciuria, loss of calcium in the urine, it's good for me now that after all calcium is more in the blood, it will be lost in the urine, because if I don't do that, the heart can stop. Loop diuretics, L for loop diuretics, they lose calcium. So that is why here it is not NS with KCl, it is furosemide. If he says what is the drug of choice for this condition, the drug of choice is bisphosphonates. I'll explain the mechanism in the later part of this discussion. And we can also give an antagonist hormone of PTH by the name of calcitonin. Calcitonin has a in it. So one way to remember is calcitonin will be sending calcium in the bones. If calcitonin will send calcium in the bones, then this will help in rapid effect, but then it's not the drug of choice because of the risk of tachyphylaxis. You see, the problem with certain drugs is that tolerance in the body develops very, very fast. Like I can mention tachyphylaxis for salbutamol, SABA. Like, you should not use SABA regularly for prevention of asthma attacks. If salbutamol is used for prevention, there is a tolerance that would be developing. So it is tachyphylaxis very common with salbutamol, and also with respect to whenever we are trying to manage hypercalcemic crisis. In fact, on this slide, the most important information that I would like you to remember is the data for hypercalcemic crisis, where NS with furosemide is the initial treatment, drug of choice is bisphosphonates with calcitonin. Now comes tetany. The scenario for tetany will mostly be like he'll begin by saying that the patient has already undergone total thyroidectomy, and usually on the 3rd day or 4th day after surgery, because though like PTH has a short half-life, the values of calcium begin to decrease by the 3rd or the 4th day. So he will say you are an intern post-op surgery unit, and you are the intern who's posted in post-op surgery unit, and the patient has undergone a total thyroidectomy, and it is day 3 post-op that you are handling this patient, and then he will start talking about that Chvostek sign and carpopedal spasm and Trousseau sign. The images of how carpopedal spasm will look like, how Chvostek sign will look like, will be discussed in the later part of this video. But at the moment, the opening line of the question is day 3 after total thyroidectomy, the patient is having carpopedal spasm and is having Trousseau sign. So he will say what is the first line management / what is the drug of choice. Here, like I have not mentioned them separately because obviously I'll try to secure the airway in a person, because in tetany the cause of death can be laryngospasm, but I need to rush with the treatment. The treatment would be I'll be giving 10 ml of 10% calcium gluconate over 10 minutes to this patient. The drug of choice for management of tetany is calcium gluconate. Calcium gluconate is the drug of choice for hyperkalemia. When potassium is very high, we give calcium gluconate. I said that in cardiology section, kidney section. And today I'm saying that calcium gluconate is being used for management of tetany, obviously because calcium values in the body are beginning to decrease because of the fact that in this patient, parathyroid glands would have been removed simultaneously. Guys, you have to appreciate that the patient underwent a total thyroidectomy for maybe a cancer of the thyroid. Commonest cancer of thyroid is usually like a papillary cancer of thyroid. So during the resection of papillary cancer of thyroid, the surgeon had to remove the parathyroid glands also, because the cancer had infiltrated into the parathyroid gland. So we can't just remove only thyroid and leave the parathyroid gland behind, which is infiltrated by the cancer. You see, the hidden part of this MCQ is, if he would have himself written the fact that during surgery the patient had had a parathyroid resection, then this would be a piece of cake for you to solve, and like there is no prizes or guesses for then answering it. I mean, your guessing or your answers would have been perfect while answering it, because the logic is that inadvertent parathyroid resection would mean that you are removing like the critical hormone source. Parathyroid glands produce PTH in our body, and therefore the manifestations would occur usually on the second or third day of life with this muscle cramps. And the reason why these patients can die, I mean, the reason for death in cases of tetany, I said that verbally, I'm writing it at the moment for your completion, that is laryngospasm. Here the examiner will also write the word laryngeal edema. He will also write the word laryngeal edema. You see, laryngeal edema is what I have described with respect to anaphylactic shock. But tetany, your answer would be increased irritability of the nerves. So the vocal cords are powered by the vagus nerve. So irritability of the vagus will trigger a laryngospasm and patient can choke to death. So I have to give 10% calcium gluconate over 10 minutes intravenously to the patient. This has to be always a slow IV injection. A lot of us, we get panicked when we are seeing a patient having stridor or when he's having breathing difficulty. We trying to push calcium fast. That will cause a cardiac arrest. Right on the top, calcium more than 13 can cause systolic arrest. So always, this injection is never given by the nurse. Doctor has to give it. When you give it first time, do it under ECG monitoring. Every time you should do it under ECG monitoring, and you must always ensure that you should not give it fast. It is 1 ml per minute. It is 10 ml or 10% calcium gluconate over 10 minutes. I have not written it because that's a practical domain, but because you will be intern soon or you are already an intern, so you would have given this and you would have noticed the heart begins to slow. There can be a risk of cardiac arrest in a patient. So on this particular slide, a lot of more useful information has been added, and normal saline now is the fluid of choice for total of 4 endocrine emergencies. Next one is like symptomatic hyponatremia. Now, like I can say, why am I describing it under the heading of endocrine emergencies? Because you are familiar that there's a disease by the name of SIADH, syndrome of inappropriate ADH production. One of the important causes of SIADH occurring in a patient can either be root cell cancer of the lung. So he will begin by describing a person who's having like diagnosed case of lung cancer, and then he's having confusion, disorientation, seizures. Why? Because lung cancer can cause excess production of antidiuretic hormone, and that antidiuretic hormone in excess will cause more water to come in, so hyponatremia will start occurring. I'll say this again. Lung cancer patient will obviously be having cough and weight loss and probable hemoptysis. So all the things related to lung cancer will be given in the question. But if you read that the lung cancer patient is having confusion, he's saying that the patient is having drowsiness, then probably had seizures. That means that SIADH has now caused a critical dilution of sodium in the body, and sodium values in the body this patient are turning out to be less than 125, which is the threshold below which we say that the person is having dangerous hyponatremia. So anybody having seizures, obviously I need to secure the airway. Seizure control measures have to be instituted. You need to raise the railing side of the stretcher, like the stretcher of the hospital bed sometimes can be like narrow. Hospital bed is wide, but the patient is on a stretcher, so he can fall from the hospital bed also. So I don't want to take a chance and risk a head injury in a person. And for this patient of root cell cancer, drowsy, seizures, confusion present, I will have to give 3% saline. This has to be a slow correction, as you're aware. Like I would not like to give a fast correction. So always it's a gradual correction done to avoid the risk of osmotic demyelination syndrome. He has also asked that how much should be the rise every day. So it is 6 to 8 millicoulomb rise per day. Otherwise the risk of central pontine myelinosis or osmotic demyelination syndrome can occur. The topic of osmotic demyelination syndrome is discussed in the end of the kidney section. When I discuss nephrology, there towards the end I've spoken about it. So SIADH can be related to lung cancer. In fact, there is one more cause, one more tumor that is notorious to cause development of SIADH, that is carcinoid tumor. So there are two causes for why person can end up with syndrome of inappropriate ADH secretion. Antidiuretic hormone, whenever it is in excess in the body, it will be acting on the V2 receptors in the kidney. And by acting on the V2 receptors, where are V2 receptors located? Your answer is principal cells in the collecting duct. A bit of physiology also I thought I'll add, because nowadays questions are integrated now. So he will ask you he may mention excess ADH acting on the principal cells in the collecting duct. and therefore it will cause more water to come in. The English word is aquaporin. Aquaporin means more water coming in the body. So dilution will cause sodium to go to less than 125. The guy is having seizures, so I need to give 3% saline. The opposite of this is symptomatic hypernatremia. Symptomatic hypernatremia is usually seen in geriatric age group, mainly due to lack of free available water. Like this old man, he had a fracture of the hip, so he's immobilized. Due to immobilization, he may not be able to get proper access to water. So hypernatremia is something that you always see in extreme age group, either very young children or like neonates, or you get it in geriatric population. It's very, very unlikely to get hypernatremia in a young, healthy person, previously healthy person, because if it is happening, then most of the time it's a lab report, because we keep on drinking water whenever we are thirsty. But little babies cannot drink water by themselves. Old people with immobilization cannot drink water by themselves. So therefore, the dehydration component can cause sodium to become higher. Now, person is having seizures, so I need to secure airway and seizure control. But then he will ask you, what is the drug treatment of choice or the fluid of choice? So you will say, I will give hypotonic solution to the patient. What is the hypotonic solution I can give is N/2 and 5% dextrose can be administered. That is a 0.45% saline. Or if this is not in the options, then I can give straightforward 5% dextrose. See, I can't give distilled water. Now, distilled water will be causing the problem with distilled water is that distilled water, whenever is being used, it will cause the plasma osmolality to fall. If plasma osmolality will fall, it will cause fluid shift across the RBCs also. So I don't want to take a risk like that. So we don't give distilled water, we give 5% dextrose. That's also dextrose plus water, but still the osmolality for 5% dextrose becomes lesser than endoplasma, because ultimately the sugar will get metabolized in the body. The rationale is for hypernatremia, we have to give to the patient dilute fluids, hypotonic solution. And for hyponatremia, I need to give concentrated fluid to the patient, that is 3% saline. At this junction, I want to say one more miscellaneous MCQ that I've said in CNS part, but it's very tempting, so I have to say it here verbally, and you don't need to note down. 5% dextrose is contraindicated in patients of raised ICP. Never give 5% dextrose in head injury patients, because it's a hypotonic solution. It will cause increased swelling in the brain. It will worsen the patient of head injury. Surgeons usually say this statement because they have to say so many other things also. They might skip this statement. So I want to cover a surgery/medicine question of your exam, that which fluid is contraindicated in a patient of head injury. It is 5% dextrose. The same fluid that I was criticizing for head injury patient is the fluid of choice for symptomatic hypernatremia. I'll say this again. 5% dextrose is contraindicated in patients of head injury because it's a hypotonic solution. It will contribute to water to go in the brain. The swelling in the brain will worsen. But the same thing that I'm criticizing is the fluid of choice for symptomatic hypernatremia. So depending on the situation, guys, we will be giving our answers for various fluids. And for hyperkalemia, I've discussed it in the kidney section, but still here we need to achieve cardiac stabilization. How do you get a cardiac stabilization? We have to give calcium gluconate to the patient. First line drug for the patient, drug of choice for this patient is to be answered as calcium gluconate. Whether he says first line treatment or whether he says drug of choice, here answer is same, guys. In some MCQs, he might write the word cardiac stabilization. I'll repeat this once again. Whether he says what is the first line drug for management of a dangerous hyperkalemia, answer is calcium gluconate. If he says what is the treatment of choice, it is again calcium gluconate. A lot of students here say, sir, why did you not answer as insulin drug? Because insulin sends potassium inside the cell, so it should be the drug of choice for management of this patient. See, I don't have time. When you give insulin drip, potassium decreases at a rate of 0.5 units every 1 hour. So if I give insulin drip to the patient, it will start working after 1 hour. I need immediate action. So this is one question where I can say both the first line management, because you can see when I'm discussing the table, first line intervention, drug of choice are being discussed separately. But this is the first time that for both of the entries, I'm giving the same answer. Whether he says first line, whether he says drug of choice, treatment of choice, the answer remains the same. As far as the theory is concerned, I'll just write it here. Insulin drip is a very, very effective drug. If he changes the language of the question and says, the doctor tell me which of the following will be causing a fall in the value of elevated potassium, then answer is insulin drip. Agreed. But initially, I don't have time. Insulin drip causes 0.5 to 1 milliequivalent per liter fall per hour. Like if the patient is admitted right now with a potassium of 7, then I'm very sure about the fact that over the next 2 hours, I'll be able to decrease the value of potassium of this patient by 1.5 points. So if he specifically mentions the word fall, or if he mentions the word lowering of potassium, if the word written is which drug will cause lowering of potassium, which drug will cause fall of potassium in the body, then understandably insulin drip. But if nothing is given, what is first line drug, what is the drug of choice, your answer is always going to be given as calcium gluconate. The rationale also, I'll say, calcium causes contraction, man. Calcium causes contraction, potassium causes relaxation. I just want to go for antagonism. Writing the data here, insulin drip causes potassium values to fall by how much? 0.5 to 1 milliequivalent. I'll just improve the handwriting here so that the decimal is not missed out by anybody. It is 0.5 to 1 milliequivalent fall per hour. Like suppose at 6 p.m. in the evening, patient was admitted, his potassium was 7. So like maybe by 8 o'clock, I'm down to 6.5 and I'll be down to 5.55 by next like 2-3 hours of admission. Okay, diabetes insipidus. This is a condition where like you can have two possibilities of central and nephrogenic variety, but the bottom line is that you are losing a lot of water from the body because there would be polyuria happening in this patient. Polyuria would cause loss of water from the body. So I need to give free water or IV hypotonic fluid to this patient. IV hypotonic fluids can be like 5% dextrose or N/2 initially. But if he says what is the drug of choice for this condition, then the answer will depend upon the central and the nephrogenic variety. If he specifies the word central, and how do you differentiate between central and nephrogenic is to check a product by the name of copeptin. I'll write about copeptin in the later part of this discussion because there I have spoken about like the test that helps in differentiating between central and the nephrogenic varieties of diabetes insipidus. But at the moment, the data is desmopressin. It's gonna be like for central, for nephrogenic, it is thiazides that would be given. Lot of these questions that come on the SIADH topic versus the diabetes insipidus topic. I've seen students like, missing out the data because when it comes to SIADH, the drug that we use is Vaptans. It is in SIADH. If he says what is the drug of choice for SIADH, then answer is Vaptan. I'll just write it superiorly once I've done with the data. If it is diabetes insipidus, then it is the drug of choice varies with the types of diabetes, like diabetes insipidus, and initial management is because you are losing a lot of water from the body, so IV hypotonic solutions would be required. Now the next entry that I'm saying is very, very peculiar. That is euglycemic diabetic ketoacidosis. The main reason for this is SGLT2 inhibitors like dapagliflozin, empagliflozin. Those are the molecules which cause a euglycemic diabetic ketoacidosis. So SGLT2 inhibitors have to be stopped. And anyway, for diabetic ketoacidosis, I've already explained, we will be giving NS to the patient. Depending on the potassium deficit, KCL would be given, and then IV regular insulin would be given. But we have to stop the SGLT2 inhibitor. So that's one of the like I can say disadvantages of SGLT2 inhibitor that you have to remember, that it can not only cause a UTI and a mycotic genital infection, but can trigger development of like euglycemic diabetic ketoacidosis as well. I'll just use this opportunity to mention that if he says what is the drug of choice of SIADH, then we have to answer molecules like tolvaptan or conivaptan that can be used in a patient. How do these drugs act? Is they act by blocking the effect of V2 receptor. They block the V2 receptor and therefore the person would be better. But initially I need to, like in emergency, I just can't give oral drug to somebody when patient is critically sick. So with seizures, it is airways seizure control, 3% saline, gradually rise the potassium back to normal, and then obviously we try to treat the cancer if possible, and we manage the patient by using Vaptans as well. Because the name of SGLT2 inhibitors have come up once again, so I want to say that they are used for cardiorenal benefit. In any patient with diabetes with congestive heart failure, diabetes mellitus with nephropathy, SGLT2 inhibitors are to be used. In fact, if they even ask you that it is a newly diagnosed case of diabetes, like let me say the scenario is newly diagnosed case of diabetes mellitus type 2, and he says what is the first line intervention, then you would be starting in this patient. So nowadays, like we obviously have to give that extended release metformin, so I'm writing the word ER, but then along with this he says nowadays there is no point of adding. I mean, we've been doing it for so many years. No, we've been giving to these patients glipizide, gliclazide, molecules like these, which are sulfonylureas, but they don't cause any cardiorenal benefit. So he says that in the newly diagnosed case of type 2 diabetes mellitus, if the HbA1c is usually more than like 8%, 9%, we can start the patient on metformin extended release with SGLT2 inhibitor. We don't need to wait for like the end organ damage to happen. I mean, earlier what we were doing was we were used to wait. Okay, when damage will occur, that is when we will start. Now he says we need to preempt because diabetes is a cardiometabolic disorder. So we don't need to wait for having damage to the kidney and heart and then starting it. That's why SGLT2 inhibitors have been added. The side effects of these are like what you already know, but I'll still write it. One of the side effects of SGLT2 inhibitor would be because it will cause glucosuria, so there would be a urinary tract infection. Second would be increased incidence of vulvovaginitis due to candida. The technical term that could be written in MCQs, MGI. MGI stands for mycotic genital infection. So next time you have a lady with type 2 diabetes and she's having recurrent vulvovaginitis, do take care of whatever medicine she's taking, and most of the time it will turn out to be a SGLT2 inhibitor. And today I also explained to you that another complication that can be developing is euglycemic diabetic ketoacidosis. Why euglycemic? Because glucosuria is happening now. So the sugar value may not be more than 250. The diagnostic criteria I told you was 250. He'll give an MCQ where value is 150. Everything else will be same. Ketonuria will be there, acidosis will be present, but random blood sugar will be given to be 150. So you will still call it a diabetic ketoacidosis because in spite of the fact that the threshold is not getting satisfied because the patient is on medicine. Now, a common error that I've seen is if he gives you a situation of diabetes with atherosclerotic cardiovascular disease, if he will himself mention the fact that the guy had already had an MI, or he had had a stroke, or he underwent a coronary artery bypass grafting, or he is having stents in his coronary artery, then you have to start semaglutide in the patient. So if he specifically mentions the word, I'll write the word that examiner will be using again and again. Atherosclerotic cardiovascular disease is the terminology that would be given. ASCVD. He will not write the word like post-MI CABG, stenting in the heart. That is like easy for you to pick up. He'll write ASCVD. For diabetes with heart failure, answer is SGLT2 inhibitor. But if heart attack has occurred in a patient, what medicine would you like to start in a person? Then your answer is GLP-1 receptor agonist. So your answer would be semaglutide. That would be once a week injection that would be given to this patient. Semaglutide has its own side effects. One of my students, dear student, he was actually doing this medicine branch only, and he took semaglutide. He ended up with pancreatitis. Very sad. I mean, I spoke to him. I was pretty bad. Then he recovered, obviously, by the grace of God. But then, sometimes I wonder why side effects occur more commonly in doctors. You would notice that. I don't know. Maybe I might be wrong, but I've seen so many people abusing all kind of drugs. They take. Nasha karte hain, right? And they are perfectly okay. And look at young doctors. They're having heart attacks. I mean, ending up with, we prescribe these drugs left, right, center. People don't have anything, and a doctor will end up with, what are the odds, right? Ending up with pancreatitis. So unfortunate, guys. But anyway, coming back to the agenda, pancreatitis, gallbladder disease, because when you lose weight suddenly, then there can be development of cholesterol stones, so there can be increased risk of cholelithiasis in this patient, GI upset, and then obviously they want to hear this word that I'll be writing, increased risk of rodents, that is increased risk of medullary cancer of thyroid. That means that this drug should not be given in those patients who are having family history of multiple endocrine neoplasia. Don't prescribe this drug in those patients who are having history of multiple endocrine neoplasia. The data of Men's syndrome will be discussed in the later part of the discussion. The fourth side effect is rapid vision loss. The reason for this is sudden fall in the HbA1c. So those they could be like damage to the capillaries of the because of the sudden fall in the sugar, the osmotic shifts again, and thereby vision loss can also be explained. So let's do a quick recap for the side effects of semaglutide. It's available daily or once a week injection, preferably once a week subcutaneous injection. Pancreatitis, must know fact. It will also help in weight loss. I've not written weight loss because that's a therapeutic benefit that it's happening. I'm not going to call it a side effect. It's a therapeutic benefit that will be happening. So pancreatitis is there, gallbladder disease due to stenosis, then is going to be increased risk of medullary carcinoma, thyroid, GI upset in a person, and then vision changes also happening. That vision changes would be due to sudden fall in HbA1c. One of the magical drugs that we are now having is tirzepatide. Tirzepatide has maximum glucose lowering capability, and they're saying that this is the magical drug which will work in patients having heart failure. It will be working in those patients having fatty liver, and obviously for diabetes mellitus. This is a dual agonist. It acts via GIP and GLP. GIP is glucose-linked insulinotropic peptide. GIP is glucose-linked insulin-tropic peptide, and then glucagon-like peptide, GLP-1. Question for you guys. GIP is produced by the K cells, which are present where? The K cells are present in the duodenum and the jejunum. I'm giving single best answer is duodenum. Yes, our duodenum contains Brunner's glands, but at the same time contains K cells. Question for you guys. GLP-1 is produced from which cells and where are they located in the intestine? Pure physiology. Don't check out your notes, guys. Where is GLP produced from in our body? We call it an incretin, right? It helps in increasing the level of insulin. And where are these cells located? GLP is produced from L cells. Simple, man. L, L alphabet. GLP is produced from L cells and GIP is produced from K cells. And this L cells are present where? In our terminal ileum. So stimulating these cells will increase the levels of GLP-1 and GIP, and both of them cause increase in the level of insulin. So this is one magical drug that will work in diabetes mellitus, obesity, fatty liver, and hopefully the burden of cardiometabolic diseases should start coming down in the next decade. We've been fighting cardiometabolic diseases, for like decades altogether. Diabetes is like a silent killer. The hypertension and diabetes are like a silent killer, and we are losing the battle due to increased incidence of heart attacks in our country. So hopefully with the introduction of this drug, tirzepatide and obviously semaglutide, we should be able to reverse that. We are trying to pull back on that curve so that the mortality levels will reduce. I think you're all aware of the fact that the most common cause of death in India and America is myocardial infarction. It's ischemic heart disease, which is the biggest killer. I would rate this particular table as the most important table of the entire aspect of endocrine emergencies. If you are an FMG student, I would suggest that if you want to read the subsequent part, I would love you to do that. But suppose you are short on time and you say, sir, endocrine mein what should I do or till what should I do? Endocrine emergency अच्छे से कर लो, you are sorted. Obviously, if you are a NEET PG or an INISET aspirant, you need to listen to even more technical aspects that I'm saying. But this is the endocrine emergency. So देखो, every word that I've said, you guys have to know, irrespective of whichever is the exam. Like FMG exam, lots of times students get 2-3 months only to prepare because they come from abroad and then you have 2 months at your disposal. तो आप कहते हो कि सर इतना तो टाइम नहीं, आप बता दो क्या पढ़ना है. तो this is the data which I have highlighted. इसका word by word verbatim data should be imprinted in your brain. Now, continuing forward, I would love you to continue subsequently. We're going to talk about diagnostics, clinical domains in the question also. So obviously, first time reading, first time listening, you have to listen to the whole thing. Second time, if you end up endocrine emergency also, I'm okay with it. Chalo ji. अब बात करते हैं diagnostic investigations. The first thing that we'll talk about is hypothyroidism. So I want to bring to your attention a couple of very interesting findings. One, you can notice that this lady she's having hypothyroidism and she's having loss of eyebrow hair. Like eyebrow hair is being lost at the moment. The technical term that they use to describe this manifestation is what is called as Queen Anne sign. You will notice that patients of hypothyroidism will also be complaining of alopecia. The hair will become like this lady. Maybe she had very lush hair initially. Now, if you look at her hair, it's literally she's going bald. So you'll have alopecia, you'll have thinning of hair and loss of eyebrow hair, which is called as Queen Anne sign. The second thing that I want to draw to your attention is that the palms of these patients are looking. The palms of these patients are like having a slight yellow tint. I'll give the reason for that also, but at the moment the word is there is a lemon. Okay, this contrast is looking better. Lemon yellow tint of the palms. Lemon yellow tint of the palms. Now let me mention the reason behind it, why the palms and soles can be having a lemon yellow tint and they look unhealthy. That's because beta carotene, like we eat vegetables like carrots, red capsicum, etc. They all contain beta carotene. This beta carotene is converted in our body into vitamin A, and for this conversion we need thyroid hormones. Beta carotene is converted into vitamin A and we need thyroid hormone. If thyroid hormone is not there, then conversion will be less. Now, if the conversion will be less, then beta carotene will accumulate in the body and you will be getting beta carotenemia. Yes, guys, this is itself an independent statement that I want you to remember for the topic of hypothyroidism in the clinical grounds. The name is beta carotenemia. The palms and the soles of the patient will look yellow because that's the color of beta carotene. It's not getting converted into vitamin A due to deficiency of thyroid hormone. It causes an unhealthy pale yellow palm and the sole appearance. As a doctor, you might be thinking patient is having jaundice. If somebody's palms and soles are yellow, you might think either patient would cooking with turmeric. Turmeric is that haldi that we use, or it's like palms and soles are yellow because of jaundice. But if you look at the white of the eye, that is the sclera of this patient is perfectly normal. So I also want to bring to your attention that whenever a person is having icterus, the sclera will always turn yellow. But in hypothyroidism patients, sclera will be normal, but palms and soles can be yellow or can be written as lemon yellow tint. Along with this, he can give a histopathology image where you can see lots of germinal follicles and a lot of blue cells present in the thyroid. I mean, you can see the area where the thyroid colloid is present. This area where I put the arrow, this is like where the thyroid follicles are present, and all these thyroid follicles are of different sizes because autoimmunity is destroying them. All these blue cells that you can see, all this dense blue infiltrates that you are seeing are basically an autoimmune damage to the thyroid glands, thyroid follicles. They're of asymmetric size. The gland is getting destroyed. So the slide that is shown to you here is that of Hashimoto's thyroiditis. From the histopathological perspective, I want to bring to your attention that all these germinal centers that are present here tells a story. The story is that there is an autoimmune impact on the gland. I'll teach you the antibodies also that are responsible for Hashimoto's thyroiditis, but at the moment, 3 images have been covered. Coin anisine with the sclera being normal, beta carotenemia and Hashimoto's thyroiditis due to this germinal centers of immunological cells that are present. If you look at the face of this lady, I can say that there is presence of myxedema. Myxedema means a very coarse and a thick skin that would be present in these patients. That's because of the accumulation of glycosaminoglycans. What happens in hypothyroidism is that in the soft tissue, there is accumulation of GAG, that is glycosaminoglycans. This affects the flow of lymphatics and therefore myxedema is actually a lymphedema. Yes guys, myxedema is actually a lymphedema. जैसे आप lymphedema पढ़ते हो ना filariasis के साथ में. But today I'm not talking about any blockage or dermal lymphatics by any worms. I'm saying glycosaminoglycans accumulation is blocking the lymphatics and is causing a non-pitting edema by the name of myxedema. Now, let us understand how in a lab report in 30 seconds will you differentiate whether patient is having primary hypothyroidism or secondary hypothyroidism. Let me write down 2 important causes and then we are good to go. Primary hypothyroidism, one of the important causes to be remembered is Hashimoto's thyroiditis. In contrast, the best example for secondary hypothyroidism is Sheehan disease. Students say, sir, how to remember this? Well, no need for any mnemonics. See, secondary basically means whenever in endocrine system he uses the word secondary, it means problem lies with the pituitary. If pituitary is destroyed, like in Sheehan syndrome, then TSH will be less. If TSH will be less, T4 will be less. If T4 is less, T3 will also be less. So if they give you a report where all the arrows are going in same direction, T4, T3 is less, that means hypo. And you also notice TSH is lesser, that means it is secondary hypothyroidism. And the best example for this is Sheehan syndrome, which occurs after delivery. You're aware that postpartum hemorrhage will contribute to. Hemorrhage is not in the gland. The lady is having a postpartum hemorrhage and due to blood loss, there is an anterior pituitary infarction that is occurring in a patient. So Sheehan syndrome is one of the causes of secondary hypothyroidism. How do you identify in a question? Very simple. All 3 arrows would be going down, down, down. Before I go forwards, I also want to add a non-obstetric cause of damage to the anterior pituitary. Like obstetric damage to the pituitary can be due to postpartum hemorrhage, but suppose somebody is having hypertension and there's a rupture of blood vessel close to the pituitary, so blood supply pituitary will be affected. Or instead of hypertension, I can say this is a child from tribal India and he's having a sickle cell crisis. A sickling crisis or sickle cell crisis can cause infarction in the area of the pituitary and therefore again the pituitary will be damaged. So like hypertension, sickle cell crisis are non-obstetric causes of damage to the anterior pituitary, and this non-obstetric damage is what is called as Simard's disease. In the MCQ, he will write a couple of reports where TSH, T3 permutation combinations will be given and he will say match which of these will be satisfying Simard's disease. Your answer would be all 3 arrows going down, that is TSH, T4 and T3 going down. Sheehan syndrome and Simard's disease both are having anterior pituitary damage. One is the obstetric cause, the second one is a non-obstetric cause. Non-obstetric reasons can be hypertension, it can be sickle cell crisis, where like sickling makes RBC sticky, so therefore the blood supply of the pituitary is getting affected. And on the left hand side, it is Hashimoto's. So before I write the report, I want to just draw your attention to the fact that Hashimoto's autoimmune etiology. So let us also write down the antibodies. which are responsible for Hashimoto's thyroiditis. So you can do the talking, guys, here without looking at the notes. Which antibodies cause Hashimoto's? Your answer is anti-thyroid peroxidase antibody, anti-TPO. The second antibody here is called as anti-microsomal antibody. Whatever I am saying, sir, verbatim, you have to remember, they have asked this even in FMJ exam. नीट पीजी में तो पूछता भाई, FMJ में पूछा कि हैशीमोटो में कौन कौन सा एंटीबॉडी होता है. ओनली टीपीओ पे नहीं बोला, बोला मार्क द करेक्ट सीक्वेंस. सो विच आर द 3 एंटीबॉडीज दैट आर प्रेजेंट? आई मीन ही गेव वेरियस परमुटेशन कॉम्बिनेशंस. टीपीओ सब में था. इट इज टीपीओ विद एंटी माइक्रोसोमल एंटीबॉडी. एक और अदर टीपीओ विद एंटी माइटोकॉन्ड्रियल एंटीबॉडी. दैट एंटी माइटोकॉन्ड्रियल एंटीबॉडी इज फॉर प्राइमरी biliary cirrhosis. So it is anti-TPO, anti-microsomal antibody. Then is gonna be the third one, guys. Yes, anti-thyroglobulin. You are aware that inside the thyroid follicles we have that pink colloid na. That pink colloid is what is called as thyroglobulin. मैं अभी दिखाता हूँ आपको. You know, if you look at this slide, you can see this pink material inside. No? You can see this pink material inside. This is the colloid. And antibodies are formed against it. So anti-thyroglobulin antibodies are the ones which are present. So I've written like one cause at the moment. I've written one cause at the moment before you for primary hypothyroidism, that is Hashimoto's. The second one is obviously iodine deficiency. But for iodine deficiency, I want to say that this is now restricted to certain geographical areas of a country. Like if I go to the sub-Himalayan areas, the Tedi Gadwal belt, the sub-Himalayan area, that is where like we can be having endemic goiter. In both of these situations that I'm writing, Hashimoto's and endemic goiter, which is due to iodine deficiency, if the gland will not function optimally. In Hashimoto, it is autoimmunity that is preventing optimal functioning. Here, there's a dietary deficiency, but ultimately T4 and T3 will not be able to, I mean, the levels will be lesser because we are discussing hypothyroidism because iodine supply is not there, but now the feedback system will operate. And the feedback system will cause the TSH values to be elevated. So most of the time they give multiple diseases and then they ask you to select which satisfies this blood report. The blood report will be given in the question like TSH will be more, T4 will be less, T3 will be less. See, T4, T3 is less for hypothyroidism. That is easy to identify. All you need to check out in the question is, guys, what is happening to TSH? Is it low or is it elevated? And your answers vary accordingly. For the initial part of the discussion, primary hypothyroidism, the problem lies with the gland, and in secondary, the problem lies with the pituitary. So these are like couple of comparisons where you have to remember the direction of arrows. In secondary, the arrows will always go in same direction. In primary, the arrows will go in opposite direction. Sometimes the questions can be two-step. They can give you this report, and then he will say, what is the next best investigation that will be done in this patient? I'm just writing NXT. NXT would mean what is the next best investigation that would be suited for this patient after this report. So because we are having damage to the pituitary, I will answer that I'll be doing a MRI head in the patient. Straightforward, guys. Secondary, if given, means pituitary is damaged, you'll do an MRI head. Suppose he gives me the report of Hashimoto's and he says, what test will you do? I'll say antibody profile. The antibody profile names are thyroid peroxidase antibody, anti-microsomal antibody, anti-thyroglobulin antibody. Those are like the names that I'll be mentioning for Hashimoto's thyroiditis. And now what I'll do is mention some more generic data for any thyroid dysfunction. No, even if he says a thyroid lump is felt in a patient or there's a uniform enlargement of gland, what is the first test to be done? It's always TSH. For primary hypothyroidism and central hypothyroidism, I've already explained to you what I mean by the word central is. What I mean by the central is that there is damage to the pituitary. So I'm just writing the data once again, guys. Instead of writing the word secondary, sometimes they can use the word central also. Primary hypothyroidism, standard data, right? TSH will be elevated and T4 and T3 in the patient will be less. And then depending on the etiology, we can be going ahead for finding the etiology. I can do an antibody profile. But in central hypothyroidism, the report will be like this. All the 3 arrows will be going down, down, down. Just I wanted you to get comfortable with the fact that if he says the word central or if he says the word pituitary, it's the following arrows to be remembered. Also remember one more fact, especially if you are an 8PG aspirant, if you will be treating primary hypothyroidism with levothyroxine, the TSH will gradually come back to normal. TSH will come back to normal. But in central, because pituitary is destroyed, even if you supply the thyroid hormone, TSH will never come back to normal. I'll say this once again, guys. TSH can be used to monitor primary hypothyroidism. It cannot be used to monitor secondary hypothyroidism. I'll say this once again. When it comes to primary hypothyroidism in a patient, what you are noticing is that TSH is elevated. When you will provide levothyroxine tablet to the patient in the form of Eltroxin or any other brand, then when T3 and T4 will begin to normalize, TSH will also begin to normalize. So in primary, as you can see, when you provide hormone supplementation from outside, TSH will begin to normalize. So you can monitor TSH 3 monthly to see whether patient is responding to treatment or not. Like you started the patient on Eltroxin tablet 550 microgram once a day. After 3 months, TSH will come down. Then you continue another 3 months, TSH will again come down. If it is coming down, you don't need to increase the dose now. You don't need to increase the dose. So like I know that my patient is responding to my treatment because T4, T3 will obviously normalize because I'm giving tablet from outside, and TSH will come back to normal. But in central variety, pituitary is busted when even if you give levothyroxine 50 microgram, 7500, TSH will still remain low. So TSH cannot be used to monitor response to treatment with respect to central hypothyroidism, but we can use it to monitor response to the primary variety. Now we focus on the Graves' disease component. Graves' disease is the condition in which the report will be like this. T4 and T3 will be super elevated, obviously because it's an overactivity of the gland due to autoimmunity, but the TSH of the patient will be suppressed. It is a suppressed TSH, almost undetectable TSH that would be present. Only on this report I cannot say Graves' disease. This report can also be present in, I'll draw it and erase it. So listen to me, I'm writing a surgical cause here. Suppose a person is having a toxic multinodular goiter, like I've shown multiple overactive nodules. I'm going to call it toxic MNG. This toxic multinodular goiter will also be producing excess of thyroid hormone. And when it will produce a lot of excess of thyroid hormone, what will happen is that the TSH values in the patient will start getting suppressed. So the message is that Graves' disease is an autoimmune condition which causes the same report, and toxic multinodular goiter is like a surgical cause that will cause the same report. So how will you differentiate? You can do an ultrasound. In patients of toxic multinodular goiter, you will notice a asymmetrical enlargement of the gland, and multiple nodules might even be appreciated by the radiologist. Or we can do a radioactive scan, and that can tell us over the hot nodules that are present. Or we can do an antibody testing in a patient for differentiating. Let me just write down the data. Guys, in toxic multinodular goiter, this is a surgical cause, so I just drew a line diagram for reference sake. I'm erasing it now. What I'm trying to say is that if it's a Graves' disease patient, then you will not be having a asymmetrical enlargement of the gland. Toxic multinodular goiter is a asymmetrical enlarged gland, but here he will always say diffuse enlargement of the thyroid gland. So with this report, ultrasound neck showing diffuse enlargement of the thyroid is sufficient for diagnosis of Graves'. However, wherever like in America where they like focus more on evidence-based medicine, he says you should be using a radioactive iodine uptake also. So when I use a radioactive iodine uptake, it will say increase diffuse uptake. Obviously the gland is uniformly enlarged and it's working more than normal. So it will say homogeneously increased diffuse uptake is present. Diffuse uptake is present. What is the radioisotope we'll be using here, guys? Is it iodine 131? Options are 131, 123. Quick answers, please. Which of the two would you be using? I'll write that down subsequently. Like at the moment, don't scroll through the notes and don't like even the, yes guys, quickly, 131 or 123. Yeah, for diagnostic purposes, we use iodine 123. For ablation, we use iodine 131. I'll write it down subsequently, guys. I'll write down the half-life of each one of them. At the moment, for diagnosis, it is 123, diagnostic isotope, right? So it's not 131 that is being used. That's for ablation. And what is the antibody which is present here? Yes, this question was again asked in FMG exam. They've asked both antibody for Hashimoto and antibody for Graves' disease. The name is TRAB. TRAB would stand for TSH receptor stimulating antibody, T for TSH, R for receptor stimulating antibody, TRAB. TSH receptor stimulating antibody is like the test that we'll be doing in this patient. Ideally, I should have all of these available, but he says if any one of them is positive with this kind of a report, I'll say this again, if this report is there and along with them, if any one of these is present, ultrasound neck showing a diffuse enlargement, a radioiodine uptake showing using 123 showing a increase uptake, or antibody present, then it means that I'm dealing with Graves' disease. Additional question which is having a pediatric overlap is what is the most common cause of congenital hypothyroidism? then don't answer iodine deficiency. That is okay for India in the Garhwal district and sub-Himalayan belt, but this is not the overall most common cause. The number one cause for why you get a congenital hypothyroidism is thyroid dysgenesis. And for identification of this, the test is done by the name of heel prick test. Heel prick test should always be done after 3 days of life because of false positive reports that can be seen in the first 3 days of life due to birth stress or birth asphyxia. So therefore, like, we should be doing this test on 3rd day of life. Then in Graves' disease, there are particular eye findings that would be present. Special eye finding which I want to bring to your attention is stare sign. They gave an image like this. You can see that the patient is literally, if I zoom in, patient is literally staring at you, and even the white of the eye, the sclera can be seen. Like in you and me, the upper 2 millimeter of the cornea. In a normal person, the upper 2 millimeter of the cornea is never visible. Here, not only the upper 2 millimeter of the cornea, but even the white of the eye, the sclera is visible. I'll say that again. In you and me, the upper 2 millimeter of the cornea is not visible because it's covered by upper eyelid, and upper part of our sclera is not visible. Here, upper part of the sclera is also visible. So this physical appearance of the wide-eyed appearance of this patient is what is called as stare sign. The question in the exam was which muscle in the upper eyelid is contributing to the stare sign, because there's a retraction of the muscles of the upper eyelid. See, in myasthenia gravis, there is a ptosis. In myasthenia gravis, we have a ptosis. Here I'm saying opposite. There's a retraction of the upper eyelid of the patient. So the question was, NEET PG question here, which muscle overactivity is causing stare sign? Then your answer will not be levator palpebrae superioris. Levator palpebrae superioris is powered by the oculomotor nerve, and oculomotor nerve is not related to sympathomimetic stimulation, but Muller's muscle is the one which gets stimulated by the sympathomimetic stimulation, and they contract, and thereby there's a retraction. The word is, there is a retraction of the upper eyelid of the patient, which gives that wide eye stare look. Muller's muscles are powered by ciliary ganglion. Now, the moment as a ciliary ganglion, you would be realizing, yes, boss, we know that this is powered by the sympathomimetic system. So because thyroid hormones have an intrinsic sympathomimetic profile, see, this is what is happening. T4 in the body is more, T3 in the body is more, so they will cause increased sympathomimetic activity in the patient. When you upgrade the sympathomimetic drive in the body, it will cause stimulation of the ciliary ganglion, and the excessive stimulation of the ciliary ganglion will now cause Muller's to contract, and that will cause retraction of the upper eyelid. This is the most specific finding that you will encounter in patients of Graves' disease. Well, what is the most specific finding that you will be getting? You will call it proptosis, because overall, not only will you be having a stare sign, but even there is swelling of the muscles of the eyeball. Yes, guys, there's a fibroblasts activity occurring in the muscles of the eyeball. So the muscles of the eyeball are swollen, and thereby the eyeball is pushed anteriorly. If he says what is the most specific feature of Graves' disease, it is proptosis. After proptosis, the second important feature which will be encountered in these patients, and I'll use a different color to highlight it, would be seen on the shin. After the most specific feature of Graves, which is proptosis, if proptosis is not given in the options, then what are you supposed to answer is this particular representation, where you can notice swelling on the shin of the patient. The skin looks very dry. It looks like small plaques on the shin of the patient initially. This is because of, again, the antibody TRAB. TRAB antibody is the villain behind all the problems. It stimulates the gland. It causes fibroblast activation in the extraocular muscles. That fibroblastic activity will cause like swelling of the eye muscle, and thereby literal sense swelling of the eye muscle, and that will cause proptosis. And it will also contribute to pretibial myxedema in a patient. They can club it with a histopathological report. You can see all these white, like once you can notice it's a magnified view of the thyroid follicles. You can see the follicle from inside, and there's a scalloped appearance. The word is, the pathologist would have also said, in the slide of Graves' disease, you will not be seeing those lymphocytic excessive infiltration of germinal center. Rather, the sign of overactivity would be scalloped appearance in the follicles. This scalloped appearance in the follicles is a histopathological finding, HPE, that would be seen with the overactive gland. It's working more than normal. It is producing more amount of thyroid hormones, but the TSH in the patient is beginning to become lesser. I'll say the theory once again. Scalloped means these white dots that you can see at multiple sites. It's like the gland is eating away the thyroid hormone relatively fast in an effort to produce more, and therefore scalloped appearance in the follicles with pretibial myxedema with this stare sign. If you combine all of them, that becomes a clinical presentation of Graves. Let's revise the stare sign component once again so that we are able to remember it on a long-term basis. So I'll just erase what I have written and just make you practice this again. This is one of the characteristic manifestations that we'll be seeing. Initially, there will be no signs and symptoms, but later signs would be coming. What is the sign that would be coming? I'll just write it once again. That wide eye stare look that is coming in this patient, it looks as if the person is like, I'll say, like, if we are very anxious and nervous, we're staring at something. Oh my God, what the hell happened? Like there's a bomb blast happening. That's when we get this wide eye stare look. And here it is present on a continuous basis. Why? Because there is a contraction of the Mueller's muscle or retraction of the Mueller's muscle, as I said, because Mueller's muscle is powered by which system? Then it is the ciliary ganglion overactivity which is responsible for this. Now, why did I choose to emphasize this is because if you are having this kind of a look all the time, then the amount of blinking that you do per minute will be lesser. No? I'll do it again. If I'm staring like this all the time in the camera, then my blink rate will be less. That will cause drying of the cornea, and that is why these patients subsequently develop exposure keratitis. So I also want to draw your attention to the word no specs here. No specs initially means that there would be like no signs and symptoms, then only signs will come. O alphabet comes for only signs. Then there is a soft tissue involvement occurring. Soft tissue involvement will imply that like the fibroblast activity in the upper eyelid is increased. Then there would be proptosis. The P is the no specs is the proptosis component that is coming. Then is extraocular muscle involvement. I'll write about this also, which muscle is commonly involved. Then cornea will become dry and then sight loss can be occurring in a patient. Especially of interest to me are the following features. One, I'll explain to you the aspect of sight loss. Second, I'll explain to you regarding the extraocular involvement in this patient. And like the rationale I can give for all of this, no specs is okay if you can remember the mnemonic, great. Even if you don't remember the mnemonic, what you have to understand is proptosis is not the earliest eye finding in patients of Graves. It develops over a finding of time. See, the most specific feature of Graves is proptosis, but it is specific, I agreed. But is it first to develop? No. First you get is a stare sign. That is why I'm saying, no, only signs are present. I hope I could give you the gist of the question. Most specific feature of Graves' disease, proptosis, but is it first one to develop? No, man, it is not the first one to develop. It will take some time to develop. So the earliest manifestation is only a sign that is in the form of stare sign or a wide eye look, as I was explaining to you, due to the overactivity or the muscle involving Mueller's muscle. Smoking increases the risk of thyroid eye disease. Now let's come to what is the eye muscle involvement seen in this condition, and like what is the second aspect is sight loss in a patient. So I'll write down both the datas and then we'll come back. If he gives you a question, what is the most common extraocular muscle which is involved in Graves? This statement is not given in Harrison. This is given in Bailey and Love. So I'm covering a surgery MCQ here. Surgery, not exactly a surgery one. It's just a fact from the Bailey book that I'm describing. Most common extraocular muscle involved in Graves' disease. Your answer would be given as inferior rectus. That's one MCQ to be remembered. The second is that patients of Graves' disease can go blind. Yes, can go blind because entering behind the eyeball is the optic nerve. No, if the muscles would be swollen because of the fibroblastic activity, they will squeeze the optic nerve and therefore there could be a blindness occurring in a patient also. So either the MCQ will say the word Graves ophthalmopathy, or instead of saying the word ophthalmopathy, he will say the word TED, that is thyroid eye disease. I'll use both of these terminologies here. The short form that is written in NEET PG is thyroid eye disease. In FMJ exam, he was a little more, elaborate. He wrote the word Graves ophthalmopathy. The question was like, what would you do in this particular patient? Then your answer is, I will straight away start the patient on high potency steroids. The treatment of Graves ophthalmopathy. Obviously, we have to give treatment of Graves disease that I'll be teaching you in the form of drugs subsequently, but that can wait. The starting of propylthiouracil or carbimazole in the patient can wait, but what cannot stop is steroids, because in Graves ophthalmopathy or thyroid eye disease, there is a risk of blindness. And the reason for the risk of blindness is that there would be compression of the optic nerve. Just like you are comfortable with the fact that in diabetes, there can be a retinal detachment and there can be an increased incidence of blindness. In Graves' disease, there is no retinal detachment. The problem is behind the eyeball, that the muscles of the eyeball are swollen. They'll squeeze the optic nerve and thereby optic neuritis can explain the risk of blindness in this patient. Two very hardcore important questions to be remembered. What is the most common eye muscle involved in Graves? Inferior rectus. Graves ophthalmopathy increases the risk of blindness by compressing the optic nerve. So what you should start is obviously anti-thyroid drugs, but prior to that, an important drug must be started is steroids to minimize the risk of blindness in a patient. Just like you guys are comfortable with the fact that for Diabetes, there is increased risk of blindness, and you might have to go for pan-retinal photocoagulation. Opthal, no, pan-retinal photocoagulation with NDYAG laser. You give injections of bevacizumab, antivascular endothelial growth factor, in patients of diabetic retinopathy to prevent the worsening and possibility of blindness. In the same spirit, we have to be aggressive in Graves' disease also. Now are a couple of miscellaneous facts related to thyroid gland. One is thyrotoxicosis factitia. Thyrotoxicosis factitia means that this patient is consuming levothyroxine. This levothyroxine could be consumed in the form of some supplements. He's taking some health supplements. He ordered them from the internet as a weight losing remedy. And these supplements could be having thyroid hormone present in them, because thyroid hormones will increase basal metabolic rate and will cause weight loss. So the guy is very happy. Oh, I'm losing weight. But he's not realizing he's eating thyroid from outside. If you eat thyroid hormone from outside, then the original gland will get suppressed, and therefore radioactive iodine uptake will become low. I'll say that again. If you take thyroid hormone supplements from outside, that is, if you're eating levothyroxine from outside, then your endogenous production will get suppressed, so low RAIU. Next is presentation of thyroiditis. Lots of time they might ask you regarding de Quervain's thyroiditis. For the subacute, that is de Quervain's thyroiditis, usually the etiology is viral, and this is the only question where you will read about painful thyroiditis. De Quervain. In fact, I'll just write it once again. You see, ESR is elevated, CRP is positive. So I have written it just below this because this would be a very good hint in the question. In no other third question will he ever mention regarding like ESR being elevated, CRP being positive, except for the topic of de Quervain's thyroiditis. De Quervain's thyroiditis is the only example where I can say it is the painful thyroiditis, or he may say tenderness elicited at different areas, like tenderness it can be at the isthmus, it can be the right lobe, it can be the left lobe of the patient. So multi-centric tenderness can be elicited with de Quervain's thyroiditis. It's usually a post URI in a patient, and the hint in the question would either be the word painful. In no other thyroid condition I have ever said the word painful, but in de Quervain's it will always be painful. And suppose you say, sir, I did not remember it. What you're not supposed to forget, non-negotiable here, is elevated ESR and CRP. That is always a feature of subacute de Quervain's thyroiditis. It's usually a post-viral. Then is a surgical domain of thyroid nodule. If it's a thyroid nodule, he says what is first investigation? It is the TSH. If the values are low, then we'll go ahead with the radioactive iodine uptake. If they're normal to be elevated, probably there could be a malignancy. So we'll do an ultrasound followed by an FNAC so that we can identify this. And the report of radioactive iodine uptake will also be helpful in taking our final decision. Most MCQs will just say thyroid nodule present. What is the first investigation? Answer is TSH. Don't answer ultrasound directly. The decision making for ultrasound is based on the TSH report in a patient. Coming to medullary thyroid cancer, this is usually related to multiple endocrine neoplasia. There is a gene involved that is RET. I'll write down the details of that subsequently. But what I need to do is, one, remember that there can be deposition of amyloid protein present here, that is called as ACAL. Amyloid is again an important topic because amyloid A beta 2 amyloid deposition is with respect to dialysis dementia. A beta is related to Alzheimer's disease. And then when it comes to like medullary thyroid cancer, we need to go for calcitonin. This is a tumor marker along with RET gene testing in a patient. So these are a couple of, like I would say, surgical overlaps that I've tried to cover up here. And if they give you an image-based question on a thyroid scan, then first he will ask you what is the radioisotope that you'll be using. Please don't answer iodine 131. Iodine 131 has a half-life of 8 days. I cannot make a patient radioactive for 8 days. So it is for therapeutics like iodine 131, guys. Where do we use iodine 131 is for treatment of choice of Graves' disease. This is for ablation of the gland. He will himself ask you what is the diagnostic isotope. It is iodine 123. As I explained to you, for iodine 123, the half-life will be 13 hours. Just remove 2 from between. So for 132, it is 2.3. Just invert the numbers there, 2 and 3. Like if I just put small markers there to help you remember, 2-3. Here, just erase the number 2. And for iodine 131, it is 8 days. So you'll have to figure out a way to remember it. If you've already figured it out, great. Otherwise, remember the way I have just said at the moment. And these are like the radioisotopes that we are using. But for diagnostic purposes, it is either of the two, iodine 132 and 123. Most of the time, what is used here for the diagnostic purpose is iodine 123. For 132, like usually it's like America or Western countries. Now, what are the reports? If it's a cold nodule, always suggestive of a malignancy. If it's like diffuse uptake, then it's grave. Toxic multinodal goiter, some areas will be having like increased uptake, some areas would be normal. So toxic multinodal goiter. Hashimoto, there will always be a suppression. The only error that anybody can make is with respect to the last two datas. That is, they will give you a one black dot, and if with the black dot you can see the gland, if you can see the gland in the background, then you will say hot nodule. But if there is a suppression of the remainder of the gland, then you will say autonomous nodule. I'll repeat this again. Cold, cancer is cold. Diffuse uptake, it's always going to be diffuse uptake, always increased. You will say, okay, this is Graves. If the diffuse uptake is substantially reduced, like you can see here, a substantial reduction in the diffuse uptake all through the gland, then Hashimoto's thyroiditis or autoimmunity is destroyed. If there are multiple hot nodules, toxic multinodular goiter, so the only thing that you're left about is a hot nodule. If the hot nodule and the background gland can be seen, then it's okay. If the hot nodule is without the background gland, then we will call it a autonomous nodule. And as I've said, the radioisotopes that can be used for diagnostic purposes can be either 123 or it can be 132, but not iodine 131. At the moment, the data for like Graves' disease is fairly extensive. The most important way for diagnosis of this Graves' disease is combination of this lab report with its plus. It is plus, right? We don't make a diagnosis just on the basis of one blood report. I need this data. This is what they've asked in the exam. Ultrasound neck, radioiodine uptake, antibody. Ideally, all three should be available, but he says at least one evidence should be available so that we can start medical treatment of a patient. Always make the patient euthyroid before undertaking any procedure in this patient, whether it is surgery, whether it is radioactive iodine. If I treat this patient without making the patient euthyroid, there is a risk of thyroid storm. And why do they die because of thyroid storm? Well, the reason I have already explained to you. The reason is usually arrhythmias or it is congestive heart failure. Next, we'll focus on the investigational choice for diseases originating from the pituitary. I'll begin by describing ACTH-dependent Cushing syndrome. Whenever you read this word, what should click in your mind is that there's a tumor in the anterior pituitary which is originating from the corticotrophs. Just like in the earlier part of the discussion, I had told you that somatotroph adenoma would mean that there would be a acromegaly, or lactotroph adenoma would mean that there is a prolactinoma. Similarly, at this moment, what are the words that should click in your mind every time you read the phrase ACTH dependent Cushing syndrome? Is either the word corticotroph adenoma, or the second word that should click in your mind is the word Cushing disease. On this, the query a lot of students is, sir, why did you not call it Cushing syndrome? Well, Cushing syndrome, the most common cause is steroid intake. So specifically, if they use the word Cushing disease, it means that there is a tumor in the anterior pituitary which is causing excess production of ACTH. In fact, the examiner himself will give you this information that patient is having ACTH dependent Cushing syndrome. There is a documentation of ACTH levels being elevated. He will say, what is the next best investigation? And your answer will be MRI of the pituitary. Logical, man. If a person is having like I can say corticotroph adenoma, that's a tumor in the pituitary, I need to demonstrate it's a tumor by doing an MRI. Now, the problem is if it's a microadenoma. If it's a macroadenoma, easy to identify. Microadenoma, let us assume it is 2 millimeter, 3 millimeter, very small, like a pinhead or even smaller, then it may be difficult to identify. So specifically, if we will ask that it's a pituitary microadenoma present and what special testing can be done in a patient, then we will answer as IPSS, that is inferior petrosal sinus sampling. Well, the rationale is that the blood coming from the anterior pituitary is coming out, the venous blood of the anterior pituitary is the inferior petrosal sinus. So if you take a blood sample from the IPS, it is basically representing the ACTH that is produced from the anterior pituitary. And if there's genuinely a tumor, genuinely a microadenoma, then the levels of ACTH would be super elevated. So there are two concepts which I've highlighted for this particular line. Whenever you read the word ACTH dependent Cushing syndrome, it means patient is having Cushing disease, which means a tumor in the anterior pituitary. If it's a macroadenoma, easily identifiable by a MRI. But suppose if he himself specifies the word microadenoma, then we can go for IPSS, that is inferior petrosal sinus sampling, because that's the venous outflow from the anterior pituitary. And there's genuinely a tumor, the value of the ACTH would be elevated in that blood. Now we'll focus on central versus nephrogenic diabetes insipidus. Well, how will this question be framed? He will begin by saying that a patient came to the doctor with complaints of polyuria. as well as polydipsia. So initially you might think that he's trying to create a question on diabetes mellitus because that also has polyuria, polydipsia. But now he will not mention the word polyphagia, weight loss and stuff like that. Rather, you can understand because of deficiency of antidiuretic hormone or resistance to antidiuretic hormone, there would be water loss from the body. If you lose water from the body, the person will start developing postural hypotension. So he might write the word orthostatic hypotension, postural hypotension, dizziness on change of position. Then he will say that because the person was passing large amount of urine, the doctor got urine osmolality done. You can understand if you lose lot of water, the urine will be dilute. And if the urine will be dilute, he will say like urine osmolality is reduced because the urine that is being passed is dilute. And urine and plasma osmolality always go opposite of each other. So if you lose water from the body, plasma will become concentrated. I'll say that again. Imagine mentally you are losing water from your body, then what will happen to the plasma? Concentrated. So he will first give you this information himself and will say that the doctor is suspecting diabetes insipidus in this patient. He will give you this history, or he may say doctor is suspecting diabetes insipidus. And how will you differentiate which variety of diabetes insipidus it is? Is it central variety or is it nephrogenic variety? Your answer will be, I will be doing a blood test by the name of copeptin levels. If it is going to be central diabetes insipidus in a patient, then the production of copeptin from the anterior pituitary will be, release of copeptin from the anterior pituitary will be lesser. But when it comes to nephrogenic diabetes insipidus, the problem is with the receptor, that is the V2 receptor is exhibiting a resistance. So whenever there is a resistance, then the copeptin levels in the patient will be found to be elevated. So earlier, like, the test that was being done mainly to identify this condition was water deprivation test. For like, I can say 2 to 3 decades, the main test for diagnosis of diabetes insipidus, anybody who become a doctor was taught this fact that the main test that is done for diagnosis is water deprivation test. But now we don't go ahead with water. I mean, we can go ahead, but Harrison says that water deprivation test ki jagah pe there's a better test available which you can check, that is copeptin levels would be either lesser or would be more. I can just give a parallel example for this at the moment. Just like insulin and C-peptide are produced together. When insulin is produced, along with that C-peptide is produced. Similarly, antidiuretic hormone and copeptin are produced together. I'll say that again. Insulin and C-peptide are released together. And when it comes to antidiuretic hormone, then another product that is released along with that released from the posterior pituitary is copeptin. Now, why I'm telling you this is like, if I say C-peptide is less, that is type 1 diabetes, because insulin is less, C-peptide will be less. If I say the word insulinoma is a condition where insulin will be more, so C-peptide will also be more. So the message is, if you are having a tumor of the beta cells of pancreas and there is a insulinoma present, then the values of C-peptide would be elevated. C-peptide level will become lesser in type 1 diabetes if beta cells are destroyed. In the similar sense, at the moment I've told you, diabetes insipidus or the central variety, copeptin production will be lesser, and in nephrogenic, because the hormone is not able to act, so copeptin levels would be elevated. That's an update in contrast to water deprivation test. And one more thing that I would like to specifically highlight for central diabetes insipidus is that in a normal person, in you and me, the MRI head will always be showing a pituitary bright spot. If I zoom in, you can see that the posterior pituitary of you and me is like very intense. It is hyper intense on our view. So this pituitary bright spot would be lost. So that's where the word will be loss of pituitary bright spot. I will repeat this fact once again. Normal MRI head is showing pituitary bright spot. This is a perfectly normal statement. If I say pituitary bright spot is lost, that is what you see with respect to central diabetes insipidus in a patient. Well, where is antidiuretic hormone produced in the body? Then technical answer is hypothalamus. But where is it released from? Then it is the posterior pituitary. So if the pituitary bright spot is lost in a patient, that means that it is a central variety of diabetes insipidus. And nephrogenic lies, obviously there is a resistance of the V2 receptors. This is totally opposite of SIADH. Why SIADH is asked to you? Well, SIADH is always asked to you primarily because of the reasons of association with tumors. One of the common causes of SIADH that you need to remember for your paper is lung cancer, that is Oat cell cancer. So he'll begin by saying lung cancer patient is having confusion, disorientation, probably seizures. There's a hyponatremia. What could be the possible reason? SIADH will draw more water, so it will cause a dilutional hyponatremia in this patient. Instead of Oat cell cancer, one more cause for this can be carcinoid tumor. Though carcinoid tumor I have discussed separately in the GI section, I want to say that carcinoid tumor can also be causing production of excess of ACTH. Just like it can cause ACTH, it can also cause ADH, and therefore like carcinoid tumor just like lung cancer can cause both Cushing syndrome as well as SIADH manifestation. Then the third cause for this is actually a pneumonia. This I've discussed in the respiratory section, that is by the name of Legionella pneumophila. The main message is that antidiuretic hormone will be more in these patients and therefore copeptin levels will be increased. But here the test that we'll be doing is a water loading test instead of water deprivation test. And another fact is, though the copeptin levels in these patients will also be increased because like there is SIADH, but the reverse will be happening here. What will happen to the plasma or the serum osmolality? It will become dilute. If you're paying attention, you will notice that in diabetes insipidus, because we were losing water from the body, the word was loss of water, so the plasma osmolality was spiking. But if you check out the data unfairly, you will notice that here I have highlighted the word decreased serum or plasma osmolality in a patient. So that difference has to be kept in mind. I'll say the data once again so that this becomes a permanent memory for you. I am saying that if in any question he is mentioning copeptin levels to be elevated, then either it can be nephrogenic diabetes insipidus or it can be SIADH. How would you differentiate is on the basis of the plasma osmolality data. Let's jot it down also so that we are able to remember it. I'll just write down the data for central diabetes insipidus, nephrogenic diabetes insipidus, and then for SIADH, the core aspects that I expect you to remember. For central diabetes insipidus, C, first remember or note down the word copeptin levels. The copeptin levels in this particular condition would be reduced. The second test I can do is a MRI head, and there is a loss of pituitary bright spot as explained to you superiorly. The posterior part of the pituitary looks or appears more like dense as compared to the anterior pituitary. So loss of pituitary bright spot is a very convincing data for the central variety. For the nephrogenic variety, the values of copeptin would be elevated. Why? Because the aquaporin or the V2 receptors are misbehaving. But here a second hint that will be present to me will be that when I will be checking the plasma/serum osmolality of the patient, the word is loss of water. You lose water from the body, the plasma will become concentrated. In contrast, in SIADH, though copeptin levels would be elevated and will be super elevated, in the MCQ you may just write the word elevated. No, you may not put 2 arrows for it. So what is the discriminatory factor? The discriminatory thing is that here he will say that when the doctor was evaluating the plasma osmolality of the person, because you are having more water coming in the system, the plasma osmolality will be lesser. So this, guys, you have to practice in your own handwriting, because if you think that in the exam you can do this, no, it's not possible. There you have to operate on remote memory. And at this that I mentioned, this is a summary box which I always like. Whenever you listen to my main videos also, I always make a summary box. So I would rate this as a must know information of this particular slide. Loss of pituitary bright spot is super easy. It is the direction of arrows that people make a mess up. So endocrine is all about, what is increasing and what is decreasing. So this is of paramount importance. Coming back to SIADH, urine of the patient will be having high amount of sodium. I mean, sodium would be going to more than 30. Well, the rationale for this condition is, why are we having urine sodium to be like 30s, 40s? Because when you have because SIADH is a condition, more water is coming in the body. More water in the body will contribute to release of what is called as ANF. I'll just write the data once again. A rationale that is to be listened to, and then you have to remember remotely in your back of your mind. That is, SIADH is a condition in which there is water excess in the body. Due to water excess, two things are happening. One is obviously there's a dilutional hyponatremia. Sodium is falling in the patient. The second thing is because of extra water in the body, there is a release of a hormone by the heart by the name of ANF, atrial natriuretic factor, that is in response to plasma volume, that when you send more blood towards the heart gets stressed and the atria produce atrial natriuretic factor, so the levels are increased. Now what will this hormone do? Atrial natriuretic factor, it is designed to cause natriuresis, and because it is causing this natri means salt loss, therefore urinary sodium in this condition is usually found to be elevated. Normally the thought process of most people is that urinary sodium should be low in SIADH, but you will notice this is always asked in NEET PG. What happens to urinary sodium? The urinary sodium will start increasing. The reason for this is natriuresis caused by a second hormone released, that is ANF. What was the primary hormone that was more? ADH. More ADH means more water. More water will cause expansion of plasma volume and will stretch the atria, and therefore ANF will be released. So I'm saying a very peculiar thing. One endocrine condition is causing a second endocrine hormone, second hormone to be released. One hormone is causing second hormone to be released. That is excess ADH, more water, expansion of plasma volume, ANF is more, and that's why natriuresis component would be occurring.
Then pituitary apoplexy means that there could be bleeding with respect to the pituitary. This is understandable. I mean, if I say the word bleeding in the pituitary, or I say infarction of the pituitary, ultimately pituitary tissue is gone. So I need to do neuroimaging in the patient. But couple of aspects that are described with respect to diabetes insipidus and SIADH are the main aspects to be remembered for this condition. For central diabetes insipidus, we use desmopressin. For nephrogenic thiazides, and for SIADH it is Vaptans. So the drug parts I've handled already, but then these tests that I mentioned, central and nephrogenic diabetes insipidus, copeptin levels are to be given over water deprivation test. Older answer was water deprivation, nowadays it is copeptin. If they give you copeptin being elevated and also mention that the plasma is dilute or serum is dilute, then it becomes SIADH and not diabetes insipidus of the nephrogenic variety, in which, because you lose water from the body, plasma osmolality will be more. So do practice this table once in your handwriting. It will become relatively easier for you. And don't be under impression that oat cell cancer will always cause Cushing syndrome. Yes, it does. But what is more common? SIADH is more common. Yes, guys, looks very surprising. SIADH is more common as compared to Cushing syndrome with respect to lung cancer. I'm not saying that Cushing syndrome SIADH comparison. No, I'm not doing that. What I am saying is that with respect to lung cancer, which is more common, then answer is SIADH, where urinary sodium can be elevated and is an example of euvolemic hyponatremia. The word is euvolemic hyponatremia. The explanation for that euvolemic part I have given in the nephrology section. But yeah, worth the effort, the information that are provided. Now, continuing in the list for disease of the adrenal glands, he will write the word ACTH independent Cushing syndrome. The moment you read the word ACTH independent, it means that the person is having a tumor which is causing excess production of cortisol from the second layer of the adrenal gland. Let me just hypothetically show this as the adrenal gland. You know, the adrenal gland can be pyramidal or can be semilunar in shape. What I'm drawing at the moment is obviously the adrenal medulla, which produces catecholamines, but my patient is having a tumor here, zona fasciculata. My patient is having a tumor in the second layer of the adrenal gland, and this tumor is like causing excess production of cortisol, and because of excess of cortisol, I can say that Cushing syndrome will develop. Why am I calling it ACTH independent? Is because in this condition ACTH values will be suppressed because there's a tumor which is causing excess production of cortisol. You see, this is an autonomous tumor. In you and me, cortisol production is regulated by our ACTH, but here it is an autonomous tumor. This tumor says, I am the boss. He says, I don't follow any rules. I am the boss. It's an autonomous tumor. It causes excess production of cortisol that will cause suppression of ACTH. And the question will say, what is the investigational choice to be done? Then your answer is very simple, CT abdomen, because after all, where are the adrenal glands located? In the abdomen of the patient. So for ACTH independent versus ACTH dependent, you have learned that the imaging modality will vary. Whenever you read the word ACTH dependent Cushing syndrome, you will always answer as MRI pituitary, and in this case it would be a CT abdomen that would be done. Now coming to the topic of primary aldosteronism. Here he will ask you what is the screening test and what is the investigational choice. Because we are focusing on the investigational choice, I want to draw your attention to a screening test for this. You see, normally like they'll ask you IOC only, but here like there's a very peculiar terminology which is asked or is present in the literature, so that's why he's asking it. For primary aldosteronism, what I need to demonstrate is aldosterone in the blood is more. So the screening test is called as ARR. ARR stands for aldosterone renin ratio. I will draw a blood sample of the patient. In the blood sample in the plasma, I will check the value of aldosterone. In the blood sample of the patient, I will be checking the value of renin. And what will happen in any patient who's having a tumor of the adrenal gland in the first layer, this time talking about tumor in the first layer like Conn syndrome, then the aldosterone values will be increased and renin values will be suppressed. Let's put it mathematically. Numerator will be more. So if you ever read a question that says elevated ARR, that is elevated aldosterone renin ratio, think in terms of hyperaldosteronism in a patient. If he says like what is the investigational choice for this condition, then simple answer would be salt loading test or saline infusion test. You see, if you give salt or saline to a normal person like you and me, that our aldosterone production will get suppressed. I said if you and me will eat salt or we are given saline infusion, then our aldosterone production will be suppressed. But this tumor does not respect physiology. The tumor is in the first layer of the adrenal gland, so it's not going to respect physiology, and therefore salt infusion test will fail to suppress excess aldosterone production. I've not written that word fails to suppress aldosterone production. That's pretty obvious that it's an autonomous tumor, so like the saline infusion test will fail here. And though in the MCQ salt loading can also be given, but then that becomes very obvious now, because when you read about aldosterone, it's all about salt. So most guys are able to guess the answer from salt loading test. So okay, let me just write it and then I'll erase it. Like when you will do some MCQs, there's a possibility that this salt loading test word would be given, but you can relate to the word salt and you can relate to aldosterone. So most guys are able to somehow figure out the answer in the question. So the examiner does not want to make it easier for you. Therefore, you will notice that salt loading test word will not be given. It is saline infusion test that will be usually given as investigational choice for this condition. At this moment, I would also like to handle a miscellaneous question. What is the most common cause of primary hyperaldosteronism? Then don't answer tumor of the adrenal gland, that is Conn syndrome that I was mentioning initially. Overall, the most common cause of primary hyperaldosteronism is BAH, that is bilateral adrenal hyperplasia. Yes, guys, the overall most common cause is not Conn syndrome. The overall most common cause is BAH, that is bilateral adrenal hyperplasia. For these patients, I will have to give lifelong aldosterone antagonist, that is spironolactone for these patients. For the person having bilateral adrenal adenoma, it's a benign one, right? Bilateral adrenal hyperplasia, there's no tumor also present, so I don't need to like go for surgery in this particular case. In BAH, I don't need to go for surgery. It is lifelong aldosterone antagonist spironolactone being given to a patient. But if he specifies the word Conn syndrome, so now you know that primary hyperaldosteronism will be having two conditions. Either it's written as primary hyperaldosteronism or primary aldosteronism. There can be two causes. What is more common? BAH. In fact, let's write it like this only. One is BAH, bilateral adrenal hyperplasia. Second is there's a tumor in the first layer of the gland that is called as Conn's syndrome. So though I'm not drawing it, it's very obvious. Like you can see, I've drawn three layers of the adrenal gland: glomerulosa, fasciculata, reticularis. So in the superior entry that I've written in purple, there was a tumor in the second layer of the, there was like stimulation of the second layer of the gland more than normal. And in this case, the word is independent. See, I'll explain this point once again. Why am I focusing on the word independent is in you and me, ACTH stimulates the production of cortisol. But check this out here. Tumor is an autonomous one. No? He is not respecting physiology. So ACTH values are rather getting suppressed in a patient. That is why the word is independent. Whereas earlier I focused on the word dependent to mainly focus on the fact that there was like a pituitary adenoma, but this time it's a adenoma in the adrenal gland of the patient. Now is primary aldosteronism, which is bilateral adrenal hyperplasia more common, followed by Conn syndrome, the tumor in the first layer. The investigations are in front of you. Then is a tumor originating from this area, that is the adrenal medulla. If a tumor is originating from the medulla, then we will call it pheochromocytoma. It will cause excess production of catecholamines. For this condition also, he will ask you regarding screening as well as for investigation. So for screening, the test to be done is a 24-hour urinary fractionated metanephrine values. In one of the FMG exam questions, this question, when it was asked, my students told me that boss, in the paper, there was no mention of the word fractionated metanephrine. This is the outdated test. It is not done anymore. So this is obviously an old MCQ, I think 21, 22, but still because it is asked, I decided to mention it here. 24-hour urinary vinyl mandelic acid level, that is VMA levels. This test is given only in Robbins. It's not given in medicine book like Harrison. So if both are given in the exam, 24-hour urinary fractionated metanephrine as well as 24-hour vinyl mandelic acid, then I would recommend you to answer, single best answer as 24-hour urinary fractionated metanephrine values. Now we will come to the investigational choice for diagnosis of pheochromocytoma. Investigational choice in endocrine system is always a blood test. So I would like to do this blood test, that is plasma. This test should always be done like the patient should be lying comfortably. Normally patient is sitting up. No, we do it in a supine position after resting for about half an hour. We don't want any positional changes with respect to catecholamine release. So make the patient lie down, let him be comfortable, and then you draw blood sample with a wide bore needle, that is plasma. But in this time, the word that we will be using to identify, like the test that we'll be doing in the patient is plasma-free metanephrine. If you're paying attention, you will notice that earlier I was saying the word fractionated metanephrine, and now I'm saying the word plasma-free metanephrine levels. So they will always tweak and reverse the data. Like there might be questions where he might write the word plasma fractionated metanephrine, whereas it is a plasma-free metanephrine levels that are elevated, and the screening test is fractionated. I mean, swapping of that is very much possible in certain questions. Now we talk about adrenal insufficiency. Adrenal insufficiency basically means Addison disease. And if he says what is the investigation choice for Addison disease, it is ACTH stimulation test. A for Addison disease, A for ACTH stimulation test. The gland will not be stimulated because it is destroyed. Now, because A and A alphabet, ACTH stimulation test, Addison disease, people are able to answer very well. So in some MCQs, he will be writing the word co-syntropin test. That word is just written to distract you. He will write the word co-syntropin test. Both basically mean the same only. Whether I say ACTH stimulation or I say the word co-syntropin test, I'm trying to stimulate the gland, adrenal gland, and it is not responding. Among all the entries that I've described for this particular table, the most important one is the first and the second entries. ACTH dependent written, MRI pituitary, ACTH dependent, CT abdomen. इतना सब सोचना नहीं है पेपर में. Autonomous, then there is ACTH decrease. That I had to explain. If you ever read a question, ACTH dependent word, right? Pituitary. If it says independent, it's a CT abdomen to be answered. If it's primary hyperaldosteronism, then we have to do a ARR followed by a saline infusion test. Saline infusion test. The words are very, very particular, right? I'm highlighting that word, saline infusion test. I'm giving saline to somebody. I should be able to suppress aldosterone production, but if it's a tumor or hyperplasia, it will not respect physiology, so the aldosterone levels will not get reduced. For FEO, obviously, this is like much more easier and people are able to get this correct. Then can be adrenal incidentaloma. Incidentaloma means simply that the tumor is detected incidentally, so a non-contrast CT abdomen. And there is a disease that is found in babies where he'll begin by saying that this is a girl child. Then he will describe the genitals of the child, that there is a clitoral enlargement. Along with clitoral enlargement, labia majora is fusing with the minora, so introitus is closed. If the introitus is closed, you would be as a doctor lost for words to explain to a mother whether it's a boy or a girl baby. So either he will be descriptive like I was and talk about clitoromegaly, fusion or labia majora with minora, or he might just write the word virilization of a girl child with clitoral enlargement. That's the characteristic opening line for congenital adrenal hyperplasia. In this particular condition, though multiple enzymes are deficient, the most common enzyme deficiency that we see is 21-hydroxylase deficiency. And in the setting of 21-hydroxylase deficiency, there's a product that is elevated in the body of this baby, that is 17-hydroxyprogesterone. So the test that we do is called as 17-hydroxyprogesterone test for identification of this girl child with virilization. What other things can be written in this question will be that the child is having salt wasting and is having dehydration. That's understandable because in the setting of 21-hydroxylase deficiency, what happens is aldosterone is not produced. If you don't have aldosterone production, then there would be salt wasting, there would be salt craving, there can be hypotension, orthostatic hypotension present in this child. Along with this, because cortisol will also not be produced. So deficiency of cortisol will cause hypoglycemia in a patient, but because the sex steroids are elevated, therefore I said the clitoris in this child will be showing a clitoromegaly, and similarly labia majora will fuse with minora, so introitus will not be visible. The reasons why salt wasting and orthostatic hypotension, I've deliberately used a short form OH because they use these short forms in the paper. So orthostatic hypotension is explained by aldosterone deficiency. This patient will also be having hypoglycemia. This is explained by cortisol deficiency. But as far as the virilization of the child is concerned, why do we get a clitoromegaly, or why do we have like labia majora fusing with minora? That is because of excess of DHEAS. So all the hormone which are lesser and more, their effects will be given in the question, and then he will say what blood work can you do on this child for diagnosis. Clinically, we know that commonest cause of congenital adrenal hyperplasia, which is an autosomal recessive condition, is 21-hydroxylase deficiency, but then there are other varieties also which I would suggest you to read from pediatrics, and so far the data is that the test that we'll be doing is 17-hydroxyprogesterone levels. Let's do a quick recap of 30 seconds for this. ACTH independent Cushing syndrome, CT abdomen. Primary hyperaldosteronism, either can be either of the two, tumor in the first layer of the gland or BAH. First is ARR followed by saline infusion. For pheochromocytoma, metanephrine is coming twice. So you need to be comfortable with when to answer free and when to answer fractionated. Lot of MCQs of the urine test may write deliberately the word free metanephrine. It is not free, it is fractionated metanephrine. For Addison disease, adrenal insufficiency, it is easy ACTH stimulation, so you will write it as cosyntropin. Incidentaloma, plain CT abdomen is sufficient, but for the pediatric domain of congenital adrenal hyperplasia, well, we need to do a 17 hydroxyprogesterone levels. Now I will mention a very interesting condition called as Liddle syndrome. Liddle syndrome is a condition in which there is a gain of function of the epithelial sodium channel. Like we have a channel, epithelial sodium channel, which normally is stimulated by the aldosterone, and thereby it is able to do its activity. But today I'm saying that this channel is working without the hormone. If this channel will work more than normal, then there will be more salt and more water coming in the body that will explain the plasma, explain the expansion of plasma volume and hypertension. And there will also be an exaggerated urinary loss of potassium and hydrogen. If you look at this diagrammatic representation here, more salt and more water will explain the hypertension. But at the same time, there is an exaggerated urinary loss of potassium and hydrogen that will explain hypokalemic alkalosis that are occurring in this patient. So the question of Liddle syndrome will begin by saying that a young man or a woman has come with complaints of hypertension explained by more salt and more water. And at the same time, there is a hypokalemic alkalosis occurring in this patient. The reason why this is happening is because there is a gain of function. Like, sometimes due to genetic reasons, we can be having a loss of function of a channel. This time it is a gain of function of the channel, epithelial sodium channel. And because the pattern of inheritance is autosomal dominant, so it will be expressed in the next generation as well. Now for this condition, the presentation will be just like that of Conn syndrome, because Conn syndrome will be having more of hormone. But in this condition, you can understand the problem is not with the hormone. The problem is with the receptor that is functioning more than normal. Now the question for you guys is, because already BP is high in this patient because of the overactivity of the channel, what will happen to aldosterone production? Yes, aldosterone production will become suppressed. What will happen to renin production? Renin production will become suppressed. Guys, I hope you're realizing that normally hypertension is always with increased renin, but I'm teaching you a low renin hypertension. I am teaching you aldosterone is low and still there is a hypertension. Let's do a quick recap here so that I can be sure that you understood me. Tell to yourself, obviously can't hear you. Tell to yourself, what is the cause of Liddle syndrome? Is it a problem of the hormone? Or is it overactivity of the channel? Your answer would be, your inner thought would be, it's a gain of function of the channel. So you get more salt and more water, hypertension. You have urinary loss of potassium and hydrogen. That is a feature also encountered in Conn syndrome, hypertension with hypokalemic alkalosis. But the difference is in Conn syndrome, it's a tumor which is causing excess aldosterone production. Here aldosterone is low, still the BP is high. Renin is low, still the BP is high. Why? Because the channel is overactive. So he can also ask you, how would you be managing this patient in a sense that how would you block this overactive sodium channel? So to block this overactive sodium channel, I can give a medicine to the patient that is called as amiloride. Amiloride is a epithelial. Amiloride is a medicine. This will block the overactive channel, that is epithelial sodium channel. If I put brakes here, then salt and water will not come in. The best way to remember this is the simple mnemonic by the name of LID, L-I-D. Any mnemonic which goes into 7-8 alphabets is useless. In my opinion, should not be more than 3 to max 5. So LID here is for the low potassium, lost in the urine. Low hydrogen, that raw hydrogen is pH is elevated. No, that's why if hydrogen is low in the body, pH will be increased. So a metabolic alkalosis is there. And then there is a low renin also. Very peculiar, guys. In all your career, you always read high renin hypertension. I'm teaching you low renin hypertension of Liddle syndrome. So the L alphabet is sorted. I is obviously for increased blood pressure, more salt and more water. D is for dominant inheritance, and the drug of choice for this condition is amiloride that will block the overactive channel. Must know fact, especially if you are a NEET PG aspirant. If you are an FMG aspirant, तो Liddle को आप छोड़ सकते हो. Remaining parts तो sir it will be same. No, I mean the common disease process will not change. Like for pheochromocytoma, whether it's FMG exam or NEET PG exam, he has to ask you diagnostics. So diagnostics will remain the same only. But when it comes to certain disorders where the problem is not on the hormone but with the receptor, then yes, Liddle syndrome takes the lead. And I emphasize once again, overall most common cause of primary hyperaldosteronism is not Conn syndrome. It's not a tumor, it's a bilateral adrenal hyperplasia. Let's now talk about few more common errors, this time with the topic of diabetes mellitus, like what is best for monitoring of diabetes mellitus. So the latest answer for this would be CGM, that is continuous glucose monitoring. You see, why not HbA1c? Because in diabetic population, the sugar rises and it falls also, na? So if you can put in a device, like continuous glucose monitor would mean that there would be a small device that can be put in the arm of the patient. You just need to bring your phone and scan over it, and it will let you know, or you can with your Apple Watch, smartwatch, bring it over it, and it can be synced, and it will tell you what is your blood sugar. Sir, a normal person checks his mobile phone at least 100 times per day. So if a person will again and again check his sugar and see it is elevated, he will try to do something about it. Now the visual memory, like my sugar was 250, then it became 350 after meal. So next time he'll try to do something about it. So the logic is that let the patient at least appreciate his sugar is elevated. Earlier people used to do pinprick, and they used to use a glucometer for evaluation. It's painful. So nowadays it says just to put a non-invasive patch here. This is CGM, continuous glucose monitor, and what it will do is it will let you not only the rise of sugar but fall of sugar, because diabetic patients can be having hypoglycemia also. No? It's not only elevated blood sugar, man, it can be fall of blood sugar also. So best for monitoring of diabetes mellitus. If I was saying diagnosis, then it is okay. If you say for diagnosis, HbA1c, agreed. But if he says best for monitoring, continuous glucose monitoring. If he says which is not a classic symptom of diabetes mellitus, so polyuria, polydipsia तो होता है, weight loss भी होता है, but polyphagia तो नहीं होता ना, because you see, you can't measure the amount of food somebody is eating. You can't measure the amount of food somebody is eating. Coming to the next question, chromosome involved in pathogenesis or type 1 diabetes. You know that this is autoimmune in etiology. The usual association is with HLA, DR3, DR4, but the question is asking regarding like which is the chromosome that is involved. So your answer would be given as chromosome number 6. And in type 1 diabetes, because of autoimmunity, there is like insulinopenia, insulin levels in the patient. If you check by radioimmunoassay fasting insulin levels, they would be less. If you do a C-peptide levels by radioimmunoassay, the C-peptide levels of this condition will also be less. In insulinoma, insulin and C-peptide levels both are elevated. In type 1 diabetes, the RIA, that is radioimmunoassay insulin levels and radioimmunoassay C-peptide levels would be substantially reduced. The peculiarity is he's saying chromosome involved in pathogenesis or type 1 diabetes. Another miscellaneous question, what is the cause of type 2 diabetes mellitus? I know that it is like due to insulin resistance. The question was like, why is there an insulin resistance? The examiner himself said that in type 2 diabetes, it has been documented that there is a insulin resistance present. He said, what is the cause of this insulin resistance? Then the reason why we get this insulin resistance should be answered as due to defective genes. There are multiple genes involved in pathogenesis of type 2 diabetes mellitus. Therefore, polygenetic inheritance is the single best answer, and this means that if father is having type 2 diabetes, son can also be having type 2 diabetes. It's not a guarantee, but it will usually be like this, that if father is having, then son can be having in later years of life. But it's not always a guarantee. It's not always. You would have seen so many people where like father had diabetes, son did not have a problem, daughter never had a problem. Maybe the next generation had a problem. It can be like this, skipping of a generation. But it's never ever going to happen that, it will be expressed in every generation. But now I will teach you a type of diabetes in which the expression will occur in every generation. That's called as maturity onset diabetes in young people. The maturity onset diabetes in young people is to be remembered MODY, because this is the rarest form of diabetes. This is the rarest form of diabetes. In maturity onset diabetes of young, there are a total of 6 varieties, out of which the most common variety, look at the peculiar question. This is the rarest variety of diabetes. Like most common type is type 2, the rarest variety is MODY. Now, the rarest diabetes mellitus ki most common variety is MODY3. Whether he says for India, whether he says for America, the most common variety of MODY found in India and America is MODY3, though overall MODY as a category, type 1, type 2, MODY is the rarest variety. The peak age of incidence of this condition is about 25 years of age. This guy is a software professional. He recently got hired by Google and he got his basic medical checkup done where his fasting blood sugar was elevated. 2-hour values were also elevated. So he's asking you, am I a diabetic? His fasting was elevated, 2-hour was elevated, more than 126, more than 200. But I thought maybe lab could be having error, so I asked him to get it repeated. He got testing done from a different lab, and even in the second lab, the fasting blood sugar of this patient is more than 126, 2-hour values are more than 200. So he's asking me, why am I having diabetes? So I said, okay, before I answer you, son, let me ask you a couple of questions. Does your father have diabetes? He says, yes, sir, my father have diabetes, but I never thought me at 25 years of age will be having diabetes. I asked him, okay, how many brothers and sisters your father has? He says, I have one. My father has one elder brother, one younger sister, both are diabetic, doctor. Everybody in my family is diabetes, but I never thought that I at 25 will be developing it. Then he says, my grandfather also had diabetes. He died suddenly. Must have been a silent MI because diabetics can be having increased cardiovascular mortality. So this guy is giving me a family history where his father is also a diabetic. His father's elder brother is also a diabetic. His grandfather was also a diabetic. Guys, the pattern of inheritance of MODY is autosomal dominant. It is for this that I had to go into this discussion. I wanted to teach you that the rarest variety of diabetes, that is MODY, actually has an autosomal dominant pattern of inheritance. And you know that autosomal dominant disorders are expressed in the every generation. So next time, if you read about diabetes present in at least 2 or more than 2 successive generations, I said if you read about presence of diabetes mellitus in at least 2 or more than 2 successive generations, like father had it, grandfather had it, and now grandson is also having it. So this kind of a clinical presentation is given to you where multiple generations are getting affected, then you will say that the person is having MODY, that is maturity onset diabetes in young. The question is still open. Why is it happening? The patient is saying, sir, why me? Why am I having it? So I will tell him that because of defective genes in your body, what is happening is that the insulin production is lesser. So this guy is inquisitive and is educated also. He says, sir, insulin production is defective. You mean that insulin is less in my body? I said, yes, insulin is less in your body. You are having insulinopenia. So this guy had done some basic research and he said that, okay, I understand that like insulin is less in my body, but then type 1 diabetes also has deficiency of insulin, doctor. So why are you not calling me as suffering from type 1 diabetes? Why are you calling me as suffering from MODY if insulin production is defective? Well, the difference is in patients who are having type 1 diabetes, beta cells are destroyed by autoimmunity, whereas in this condition, beta cell mass is normal, but still the production is defective due to genetic reasons, and therefore this person will also have insulinopenia. I repeat my fact, beta cell mass is always reduced. Beta cell mass is always reduced in patients of type 1 diabetes mellitus, but beta cell mass is always normal with respect to maturity onset diabetes in young people. That's the core difference that you have to understand, that in type 1 diabetes, there is autoimmunity that is destroying the beta cells. Here, there is no autoimmunity. Still, insulin production is less. Why? Because genes are not working. Therefore, the ability of the beta cells to produce, like if I put in scientific words, beta cell depolarization is defective. So another question in your exam, that is NEET PG, said, what treatment can be given to patients of MODY3 so that we can, establish euglycemia in this patient, because beta cell depolarization is defective. So I will give a medicine that will cause more beta cell depolarization, and the drug that will cause beta cell depolarization much more than what normally happens in the body is glipizide. Glipizide is a sulfonylurea. Glipizide is a sulfonylurea. It is also written in pharmacology as insulin secretagogue. You see, since the beta cell depolarization electrically is defective, so I can increase the magnitude of beta cell depolarization by using glipizide. This is again very peculiar because in no other variety of diabetes do you start your treatment with sulfonylureas. Glipizide is a sulfonylurea. Na? We don't start treatment of diabetes with sulfonylurea. So the question in the paper said that in which variety of diabetes would you be starting treatment with sulfonylureas? Your answer would be given as glipizide. Your answer would be MODY3. We can use any one of the sulfonylureas or insulin secretagogues. The examples are like glibenclamide, glyburide. There are so many of them that begin with alphabet G that you get tired of reading them. But the main message is that for type 2 diabetes, we obviously will start with extended or like modified release metformin. And the update nowadays says that we don't need to add sulfonylurea. You can see earlier for every patient with type 2 diabetes, we were usually giving like combination of metformin with sulfonylurea. But now he says that you have to combine with. This is an important update. SGLT2 inhibitors, because you want to prevent the damage to the heart, you want to prevent the damage to the kidneys in a patient, because most patients will be having cardiovascular impact. So diabetes currently earlier it was, we used to wait for comorbidity to develop. Older guidelines were, we used to wait for the comorbidity to develop and then treat the patient. Now he says no need for waiting for comorbidity. Start a treatment with metformin with SGLT2. But in which variety of diabetes would you be starting treatment with sulfonylureas? Answer is MODY3. At this moment, I also want to say a platform has given in the MCQ MODY2, 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 just to make it sound difficult. Sir, MODY2, no treatment is required. In your exam, he will not ask you MODY 2 because there is no treatment required for that condition. A MODY 2 is a very mild form of MODY. It just causes hyperglycemia, but in a mild to moderate range, not like in a severe range. So most of the time, like exam, you see platforms will always try to make things difficult, and in paper they ask you more common things. MODY is again not a very common thing, but if they're asking this, then for a examiner to ask you MODY, that itself is unjustified. Now to ask you in which variety of MODY treatment is not required is still even more unjustified. So it's okay. I mean, I have told you the answer MODY 2. I mean, no drug treatment required. But for MODY 3, guys, it is like glipizide that would be used in the patient. Most common variety of diabetes is type 2 diabetes, and the best way to monitor diabetes is not HbA1c, and it is continuous glucose monitoring. As far as the values are concerned, they're pretty straightforward, so we can just quickly go through them. For diagnosis of diabetes, the fasting values, obviously in a normal person, I'm first talking about normal person, the values would be less than 100. After 75 gram glucose, we will once again be drawing a blood glucose value, that is 2-hour value. This is not called as postprandial. This is not this is not a postprandial value, guys. This is called as a 2-hour value. Postprandial value is when the person has eaten food. He did not have his food now. The person did not have any food. Therefore, like the values here would be less than 140. I repeat once again that nowadays for diagnosis of diabetes mellitus, we don't need even these testing. We can straight away do a HbA1c. For treatment, we have to start even for type 2 diabetes without a comorbidity. The treatment can be started with the metformin, extended release, and SGLT2 inhibitor. What is the cutoff HbA1c at which we'll start the treatment, I'll discuss on my subsequent slide. But at the moment, I just wanted to tell you the update, plus talked about MODY 3, where we use sulfonylureas for treatment. And an important thing is that postprandial value is not useful for diagnosis of diabetes. Here, when this 2-hour value question was asked, would you believe this, that in NEET PG paper, they asked this question, which of the following is not useful for diagnosis of diabetes, and people were struggling. Sir, postprandial value is not useful for diagnosis. It is useful for monitoring a patient, not for diagnostic purposes. For diagnosis, in the oral glucose tolerance test, the value that you will answer here will be called as 2-hour value. This is the 2-hour value less than 140 milligram that is useful for diagnosis, not postprandial value. Then he created a situation. He said, like, you are a doctor with the armed forces, and today a guy has cleared NDA exam, but in the medical you have failed him. In the medical, you have failed him because his fasting sugar value was between 100 to 125. So he said, like, you have failed him in the medical, and this boy is asking you, doctor, on what medical grounds have you made me unfit? This guy is saying, like, my father was also in the army, grandfather was also in the army, and like, doctor, it was my dream to be in the army. You are ruining it. So you will say, sir, according to the service rules, I cannot hire you because anybody with diabetes cannot be hired into the forces. This would be technically answered by you as, like, the question was on what medical grounds the doctor can make this person unfit for service in the army. Then answer would be given as IFG, that is impaired fasting glucose. So this guy is not satisfied with my answer. He says, sir, I want to appeal against it. I said, okay, give a written requisition. We will do your testing tomorrow again. Tomorrow morning, again, he will come fasting, at least for 8 hours. After fasting sample, I will say, sit down. Now we will make you drink 75 gram glucose. After you consume glucose, you are not supposed to walk, because after drinking glucose, if you will do push-up, sit-up, exercise, then sugar will become normalized because muscles will use the sugar. So I'll tell this guy, don't exercise after you consume sugar. Sit on the sofa. We're monitoring you by CCTV camera. Don't move around. Don't try to cheat. He says, okay, boss, I won't. Now he's sitting on the sofa. After 2 hours, a technician will call, and the value of this is between 140 to 199. Then this guy's career in the armed forces is over, in a sense that his appeal will also be rejected. We will say, sorry, boss, I really cannot help you. This would be impaired glucose tolerance, that is IGT. A lot of guys casually answered the first one is impaired glucose tolerance. The first, that where I put the star mark initially, that is IFG, impaired fasting glucose, and the second one is IGT, that is impaired glucose tolerance. I mean, English, no, when you make him drink glucose, then impaired glucose tolerance. When he's fasting, then it is impaired fasting glucose. And the extreme right hand side has been asked so many times that I don't think so I need to say it, that fasting more than 126, 2-hour values more than 200 are sufficient for diagnosis of diabetes mellitus. Obviously, I need both of them, like fasting as well as the 2-hour value. And if it is a single fasting value, then I need at least 2 fasting values. I repeat that again. I need both of these values. That is okay. So instead of writing like and, I can say, usually what the book says at this point of time is, he says in brackets, more than one value required. What is meaning of the word more than one value is that suppose if a person comes only with one fasting value, 130, 140, whatever. He says, I am a diabetic. I said, sir, please come to me with a second report of fasting and then I will let you know. So the diagnosis is made on the basis of the combination of the two. I'll remove this word one value just to explain. This was only for explanation. What I have to explain to you is that you need two reports. Fasting more than 126 or two values more than 200. Suppose somebody came with only one fasting report, then we will not take that as single report as accurate. I'll say get it done again tomorrow. And if two fasting reports are more than 126, then it is sufficient for diagnosis of diabetes. So here I'm writing an and I'm also putting a comma to say more than one report. This meaning of the word more than one report is like, suppose somebody came with only one fasting sugar of 130 and he says, my company had asked me to get an annual medical checkup done. My fasting sugar is 130. Am I diabetic? I said, maybe lab can make an error. So let's get it tested from a different lab. And if from a different lab also, we notice that the fasting value is more than 126, I'll say, okay, man, you are a diabetic. As far as glycosylated hemoglobin is concerned, the normal value has been asked. This would be less than 5.6%. Yes, not 6.5 guys, less than 5.6. Values between 5.7 to 6.4 is what is called as pre-diabetes, where nowadays high-risk patients may be started on metformin. And for diabetes mellitus, obviously the cutoff is going to be uniform, that is value more than 6.5%. If he says best for long-term control of diabetes mellitus, here he's talking about long-term control. You see, initially when I was talking about the question, it was about monitoring of diabetes. It was not about control, it was about monitoring of diabetes, because in diabetes, sugar values can rise, but they can crash also. Now, hypoglycemia is very common in diabetics also. Sugar, let me say this is euglycemia. If this is euglycemia, sugar can rise and sugar can fall. If you monitor the sugar all the day, in diabetics, sugar will be rising and fall also. HbA1c cannot tell you about the fall. If somebody's sugar is crashing, HbA1c will not tell you about the fall, and lots of time patients become sick because of the fall. They can become unconscious, have a seizure also. So the message is, for monitoring, it is CGM. But once the diagnosis of the patient has been nailed, for control evaluation, like glycemic control is what I'm talking about. What I mean by control here is glycemic control in a patient. The best for long-term control would be answered as HbA1c. If I modify the question and say what is the best test for severity of diabetes mellitus, the answer would still remain as glycosylated hemoglobin. Like suppose I have three patients A, B and C, all of them, one is having HbA1c of 8%, second 9%, third 10%, then 10% will be having more complications as compared to 7% or 8% respectively. So severity of diabetes mellitus is also determined apart from monitoring or long-term monitoring is CGM, glycemic control is HbA1c, and severity of diabetes mellitus is again HbA1c. Now, because HbA1c is a very easy answer, so they changed the question, like the Vacutainer that is used for this is the purple Vacutainer. I mean, the color of the Vacutainer that we use for evaluation. This is that Vacutainer that we take for HbA1c. So I don't need to like write the word purple. It is already visible. Purple or magenta color Vacutainer that's used for drawing the blood sample. For glucose is gray, G for glucose and G for gray. But for HbA1c it is gonna be purple in color. Because HbA1c is so common an answer, so he changed the MCQ. He said, what is best for short-term control of diabetes mellitus? Then your answer would be given as serum fructosamine. That's such a relief now. For diabetes, every time we are reading, it's only HbA1c all the time. But this time the answer is serum fructosamine, which may also be written as glycated albumin. Both of these are retrospective tests. They do not tell you what is the blood sugar today. They tell you an average blood sugar. I repeat my statement, both of these tests that I'm telling you, HbA1c and serum fructosamine, they are retrospective tests. They are not affected by the food intake that I have consumed today. They are affected by the food intake in the previous 3 months. So these are retrospective testing that is done here. He will say this retrospective testing is valid for how long a duration. Then for HbA1c, the retrospective testing gives you an average estimate. I mean, what is the rationale of doing HbA1c is it will help you by calculating a EAG, estimated average glucose, not a 1 day, not a 2 days, not a 1 week, but it will give you estimated average glucose of as long as 2 to 3 months, that is 8 to 12 weeks. I repeat my statement. If a diabetic patient is partying and is eating chole bhature and chow mein and is enjoying his life, then HbA1c will be elevated. When he comes to you after 3 months, he's bluffing. He's saying, yeah, doctor, I eat my medicine, I have controlled my diet, everything is fine. But on festival time, he was partying. So how do I know whether he's lying or he's telling me the truth? He says, sir, I've been taking medicine. I've been following dietary advice that you've given me. If I want to find out whether the patient is lying or not, just get HbA1c done. If it is elevated, the guy is simply bluffing. Or second possibility can be my drugs are not working, right? That's another possibility. But most of the time it is patients are lying. They've not done dietary discretion. They have not taken medicines regularly. So EAG is average estimated glucose of average, not 1 or 2 days, but for 2 to 3 months. And thereby lets you know that your patient is bluffing. In contrast, when it comes to glycated albumin, it will also help in evaluating estimated average glucose. But for how much duration? Then it is previous 2 to 3 weeks, because half-life of albumin in our body is about 15 to 21 days. So remember the word EAG, the full form is estimated average glucose. Estimated average glucose for 3 months. That's HbA1c. That's why word is long-term control. But if you focus on the inferior word, short-term control, then it is going to be serum fructosamine. Two must-know hardcore general medicine questions right now are: what is the best test for glycemic control of diabetes from long-term perspective? That is 8 to 12 weeks, 2 to 3 months, HbA1c. What is the best test for short-term control of diabetes mellitus? Then the EAG value is valid for 2 to 3 weeks, which is also called as glycated albumin. Now, why can you be having a falsely elevated HbA1c values? The answer is anemia. Lots of Indian patients are anemic, and as a result of this, the values can be falsely elevated of HbA1c. Another reason for elevation of HbA1c can be thiazide group of diuretics. Like if you're seeing somebody who's hypertensive and he's having HbA1c which is rising, one reason could be thiazides which are continuing in the patient. That is why like thiazides are used sparingly, like as a last resort. Otherwise, like anemia and thiazides are two important reasons for false elevation, and if you stop thiazides, the values usually start coming back to normal. The opposite MCQ of this would be falsely low. So if hemoglobin A lifespan will be reduced, like if somebody is having thalassemia, hemolytic anemia, then the values can be falsely low as well. So these are like 4 very classical, I would say, hardcore general medicine questions that have to be remembered.